Indian speakers, which will speak on women's health from womb to tomb and anemia to cancer. So let us start our EVECON conference. Once again, I welcome you all delegates, faculty, and IMA leaders. I request Dr. B.L. Deshmukh sir, our immediate past president, to come on the dais to chair the session. Along with him, I will invite Dr. Rohini Padve madam, chairman, cultural committee, IMA MS, and Dr. Asmita Bodhe, gynecologist, to start with the session. Pathologist. Hello, you can start with the session.
Good morning, everyone. Good morning to the fresh and loving faces. We'll start with the session by Dr. Josna Kulkarni madam. To introduce her, it's a great pleasure to me. Madam is studied in Mumbai, born and brought up in Mumbai, studied at Nair Hospital, Mumbai. She has performed lab cholecystectomy in Pune for the first time. She is the pioneer of cholecystectomy laparoscopic in Pune. She is the first female surgeon in the world to do the lap cholecystectomy. In 1992, she started India's first animal lab for lap surgery training, trained more than 400 surgeons all over India till date, conducted many laparoscopic workshops in India and abroad. In 2015, she received Sushruta Award from Mumbai Medical Foundation for outstanding pioneering work in laparoscopic surgery in India. In 2018, she was selected to deliver prestigious Dr. G.M. Patke audition during Massacre in Mumbai. She has also received dedicated Lifetime Achievement Award from World Peace University and Mammogram College, Medical College in Pune. She has got a lot of awards in her back. Since 1991, she has conducted workshops, demonstrated surgeries in India and abroad, Sri Lanka, Bhutan, Pakistan, Bangladesh, and many more. It's my pleasure to invite Dr. Josna Kulkarni madam for the lecture. Madam, please.
इकडे थांब इकडे हा हो रेडी
Good morning, everybody. Dr. Asmita, thank you very much for your kind introduction. Respected teachers, seniors, my colleagues and friends on the dais and off the dais, a very good morning to all of you. Today I am standing in front of you with mixed emotions, happiness and gratitude. I am grateful for being felicitated today, that is what Dr. Deshpande has told me, for being the pioneer and the first lady surgeon in India or rather world to perform laparoscopic cholecystectomy. So a big thank you. To the president of IMA, Dr. Meenakshi Deshpande, and her team for inviting me to take the honor. When they told me that also I could give a lecture and after the felicitation, but I think it's going to be in the reverse order, I surely accepted the offer. I thought I would take this opportunity to share my journey of laparoscopic surgery with this august gathering. Laparoscopic surgery came into my life and it changed not only my life, but I think all of us around us. Lots of surgeons in Maharashtra and India have witnessed my laparoscopic surgery demonstrations, which are performed at various workshops. After having spent more than 3 decades in laparoscopic surgery, looking back, how and when did this journey start? How did I overcome the obstacles? And how did I reach where I stand today? I think I would like to share all this with you today. I was born in Mumbai, Dadar, and I'm the youngest of the 3 siblings. My school was King George, and which is now known as Raja Shivaji Vidyalaya. And the pre-medical college was Jai Hind, where I spent 2 years of pre-medical years. The medical education, both for MBBS and MS, I took in Kopiwala National Medical College, which is in Mumbai, and the GYN Hospital. Being born in the middle class family, importance of education was very much stressed by our parents on the minds of all 3 of us. While studying for MBBS, I would be impressed by the various branches of medicine, but somehow I was always attracted to surgery. In the specialty of gynae and obs, besides deliveries, DNCs, cesarean sections, and hysterectomies, there was no 5th operation in those days. In medicine, when we talk about consolidation of the lung, one has to imagine what are the pathological changes which happen in the lung. But in surgeries, in a case of, say, acute appendicitis, we can actually see the inflamed appendix. We can remove it and make the patient better. So in surgery, we are able to cure most of the surgical diseases. But in medicine, we can only keep them under control and not cure them. So this was the very reason why I wanted to be a surgeon, first of all, because that was the basis of me becoming a laparoscopic surgeon later. So this is the reason I decided not to do post-graduation in gynae or in medicine. Only 2 weeks are left to fill the form for further postgraduate studies. And that is the time when I met Sanjay for the first time, my husband. I'm from Mumbai and he was from Pune. During those days, there was a vast difference between the culture of the 2 cities. And at no time I wanted to leave Mumbai and go somewhere else. But on inquiring through one of our family friends who was in Pune, Sanjay just befitted my desire of having a tall, skillful surgeon husband. And so I decided, let me give him a chance and just go and meet him. So I went to Pune because he was already doing post-graduation and didn't have leave. So on one Saturday, I went to Pune and then that's where we met. On meeting him, after a while, when I asked him, since he was going to be a surgeon, would he like his wife to be an anesthetist? To that, Sanjay's prompt answer was, I would like to have a doctor as my life partner, but she should pursue the career in the branch that she adores. I don't think you should be an anesthetist if you choose not to be. Both husband and wife can be surgeons, and I will always extend my help and encouragement to her. I think these words were enough for me to make a decision. I was so impressed by Sanjay's answer and his thoughts. That instantaneous decision was, yes, he could be my life partner. On 7th of March 1979, we got married in Mumbai. Whatever I am today and whatever I have achieved in my surgical career, I think the foundation stone was laid by Sanjay on that day when we first met. Whatever little name I have made in the surgical field, I would like to dedicate my surgical career to Dr. Sanjay in front of all of you. After completing MS in general surgery, we both went to UK. Sanjay took training in urology for 5 years. My elder daughter Vicky, who is a physician now in the United States, was born in Mumbai while I was doing masters in surgery. Second daughter Preeti was born in England. While preparing for FRCS, I used to study in the night after putting both the daughters to bed. After clearing my second part of FRCS, when I told my elder daughter, who was then 5 years old, Vicky, do you remember I used to study because I was preparing for an exam? I have passed that exam. I was so excited to tell her because the day I got the result, Sanjay was not around, he was still on his duty, and the only person who could really understand because the second daughter was only 2 years old. So I was excited to tell my 5-year-old that I passed that exam. It was a big thing for me. So on hearing this, Vicky very promptly asked me, now that you have passed that exam, does it mean that you don't have to go to the hospital? What an innocent question. I've still not forgotten that. Because according to her, I was her mother. Going to the hospital, whether I'm a surgeon, whatever I do outside, did not matter to her. So this sentence has been engraved on my mind, the question, and I've not forgotten it today. It just made me realize the reality of child psychology. That very moment I decided, whatever progress I will make in my career and to whatever heights it might take me, in the eyes of my 2 daughters, I would always be their mother and would remain so forever. I think each professional woman, whether she's a doctor or another profession, always feels guilty by balancing the professional and personal life. And balancing both is tricky, but I think it is very important. When we had the first time there was cloning of the sheep, I thought I would take this opportunity if somebody can clone me. I would like to have 6 Jyotsnas. One will be a surgeon, 2 will be with my 2 daughters, 1 will be with the husband. So we are managing and trying to do all the roles as a woman. And physiologically, we cannot disown the responsibility of the children because physiologically we bear them. And so we have different psychology. In January 1987, after spending 5 years in UK, we returned to India. Pune was a new place for me. So I worked as a pool officer for 2 years in KM Hospital, Pune. Those days there was, I think that scheme is still there for people who have gone abroad for some years. And once they come back, just to get a footing, the government has this scheme, not just for doctors, but for all professions. And the pay is given by the central government. So the hospital is happy to have a qualified doctor whose pay comes from the government. And it's only for 2 years. So those 2 years helped me to get to know the surgeons from Pune since I was new to Pune, and also I got associated with Pune Surgical Society. In 1990, Dr. Sanjay was planning to visit USA to attend his urological meeting, and he wanted me to accompany him. But leaving the 2 daughters behind, though my in-laws were very cooperative, I didn't want to leave my 2 daughters in India for about 2 weeks and go there to USA just for fun. So I contacted one Indian plastic surgeon from Pune who was settled in USA so that I could learn breast reconstruction from him, because being a female surgeon, females are very comfortable showing their breast problems to a female surgeon. So I wanted to do something further with that. But I think there was something different but better waiting for me there. While staying with Sanjay's cousin in Oklahoma, we saw an advertisement on TV about laparoscopic laser cholecystectomy. There was information in that ad regarding the removal of the gallbladder with the stones through tiny incisions rather than the formal big incision. And once we rang on that number, the secretary said, I would talk to the boss and find out whether you could come and attend. By our luck, Dr. Bob Arnold, who was the surgeon performing laparoscopic cholecystectomies those days in Baptist Medical Center, he was a very skillful surgeon. On contacting him on phone, he was very receptive and gladly said that he could visit his unit to see laparoscopic surgeries. And in those days, they were not very strict. I think after 7/11 bombing, they became strict about who could go to the hospital, and they started asking for blood tests and immunization tests and all those things. But in 1990, this did not exist. You could go to the operation theater, visit the hospital once you have talked to the concerned authorities. So this surgery of laparoscopic cholecystectomy was being done only in that center in those days. So instead of seeing breast reconstructive surgery, which I had already organized with a doctor, plastic surgeon in New Jersey, we decided to go to Oklahoma because breast surgery I could have watched there as well, but laparoscopic surgery was not being done anywhere else. So just looking at the ad, we took a decision that we have to fly from New Jersey to Oklahoma. And I've still not seen the face of that plastic surgeon with whom I had organized so many surgeries. I'm sure he was very cross with me. So in Oklahoma, we had this advantage, as I said, to see both breast as well as laparoscopic surgery. We stayed there for nearly 2 weeks, and I must have seen about 40 gallbladders being removed laparoscopically. As I said, I was fortunate that as I said, he was a very skillful surgeon, So while returning to India, before we departed, I bought a clip applier worth $500 then, and clips worth about $400. And my treasure was a video cassette which was given to me by Bob Arnold for full unedited recording of a laparoscopic cholecystectomy. We returned to India in May, and then my struggle to get the equipment started. I got a railway pass to travel from Pune to Mumbai and back, and visited Kalilkar Surgical Center Biomedical from time to time as I would have time. I had made sketches of the instrument, the hand instruments, with their length, how they looked, and I think that time we didn't have a very smartphone, so I didn't have photographs. Today I have but I had the sketches of the instruments for use for laparoscopic surgery. I showed those sketches to Mr. Kalilkar from Kalilkar Surgicals, and requested him to make those hand instruments for me. I also wanted to purchase endovision camera, telescope, light source, light endovision separator from Chimko Biomedicals because he was the one who was the agent for STARS company. And the budget for the same at that time was 5 lakhs, and I didn't have any money in my pocket. It took very long time to get loan sanctioned. It was so difficult those days to get loan. Today you get hundreds of calls up asking whether you want loan, and normally very annoyed when they give you at a time when you want to relax. But it was difficult those days to get loan. So it took time to get the loan and to get the equipment. After having acquired the equipment, now I need a patient who would benefit from laparoscopic cholecystectomy. Those days in Pune, there were 3 doyens who were doing regular cholecystectomy. Dr. P.K. Bharucha from KU Hospital, Pune, Dr. M.J. Joshi, who had a hospital on Holy Road, and Dr. Edimam Sir from Jahangir Nursing Home, and they were the stalwarts for cholecystectomy. I went and met each of them, told them about the new people's technique of removing gallbladder, and also told them that I had come back from USA after having learned the technique. 17th of November 1990 was the Saturday, to be precise. And Dr. Edimam from Jahangir Nursing Home called me and he said, I would like to go and see a patient whom we can host for surgery for laparoscopic cholecystectomy. Dr. Edimam used to have his OP list on Mondays and Wednesdays. And he asked me to perform the surgery on Monday. But my problem was, he was going to assist me. There are four ports. I need 2 more hands. And during that same weekend, Sanjay was away. He was in Singapore presenting his paper in a conference. So I requested Dr. Elibam that, sir, once Sunday is back on Tuesday from Singapore, I would rather perform the surgery on Wednesday so that he can help me. Dr. Elibam was very clear. He said that for my convenience, he cannot postpone the surgery. Especially because that patient was a rickshawala moved to one of the trustees and he was occupying a free bed. And just because Sanjay would come and help me, he didn't want him to occupy 2 extra days for the free bed. He said, if you don't do it on Monday, I will open them. So I think I had no choice but to operate on Monday. I just told him, please finish your list and then give me the theatre because I don't know how long I will take. So by about noon time on that Monday, Dr. Elibam had finished his rest of the surgical list and the theatre was handed over to me for my first ever laparoscopic cholecystectomy. The procedure of laparoscopic cholecystectomy was new to all of us. The instruments were also very primitive in those days. Many of them were not insulated, neither did they have a ratchet or a catch so that you could have issues for a longer time. Not there was a tip which rotated. So they were all very primitive, and this is the photo of instrument which I used for the first time. So many times once we started the surgery, many times it so happened that the grip on the fundus of the gallbladder would come away because everybody is busy looking at the TV. And they don't know when the hand has been so that there is no ratchet, there is no catch. The liver would fall and you have to start all over again. I have to back out the camera, hold the fundus, give it to the assisting surgeon. And then, at the end of 4 hours, in spite of all these difficulties, we managed to finish the laparoscopic cholecystectomy and the intact gallbladder along with its stones came out very safely without injuring any other organs in that body. I think that was a great success according to us. Now, for the same gallbladder, which I did that day, I will take 20 minutes today, but 4 hours was a big time, but it was most important was that it was done very safely. After about 1.5 hours of starting the surgery, apparently Dr. Elibam had left out of frustration because he could see that everything is falling, you have to back out, start all over again. And his place was taken by the surgical assistant of Jahangir Nursing Home. But I was not aware of this at all. Here I finished the surgery. I didn't know when he was replaced by the surgical assistant. I was so engrossed looking at the TV. At the end of the procedure, I realized how hungry I was, not having eaten anything that morning of the surgery before surgery. I did not like we go for exam, we don't want to eat, we're so nervous. And how my eyes were sore looking at the TV monitor for continuously for 4 hours, and also not having slept the previous night, thinking about the surgery next day morning. But this did not bother me, because the pleasure and the happiness of performing my first ever laparoscopic cholecystectomy was far, far greater than my hunger or my sore eyes. 1890 was the day which is to be written in gold for me. The patient was a rickshawala and his name was Mr. Gaikwad. About 1.5 months after the procedure was done, one gentleman came to see me in my clinic. I examined his abdomen and asked if he had any complaints, but he denied. Naturally, I asked him, so if you have no problems, why have you come to see me? To which his answer was, Madam, do you remember you had removed my fish feet? For a moment, I was speechless. I said, fish feet in a man, because we know colloquially we call fish feet for interest. So what does he mean? And then it dawned on me, what he meant was the Implant fish feet and the gallbladder. So that is, I had moved his gallbladder. Oh my God. I had seen Mr. Gaikwad in those striped uniform of the hospital. I just saw him had explained that they are going to remove his gallbladder with tiny holes. It's not possible. I will do it open. And a day later, I stopped going to the hospital because Dr. Elibam said, you don't have to come. I will take care of it. I will discharge him when he's ready. So I did not recognize him in his normal clothes. But once I realized that he's the guy on whom I had removed the gallbladder, I wanted to look for those scars through his hairy abdomen. But those were so tiny and his abdomen was so hairy that I could hardly see them. Then I bombarded him with a series of questions because I was so eager to find out how everything went after the surgery. I wanted to know how he was, whether he had any trouble, any pain, whether he had any loss of appetite, and so on. He said he was discharged by Dr. Imam 3 days after surgery. He took rest for 10 days at home, and 2 weeks after surgery, started driving rickshaw. I had given him my visiting card in the hospital, and I had asked him to see me about a month after surgery so that I can get some follow-up. So there he was to see me because I had asked him to come, but he had no complaints whatsoever. I was so delighted to hear that, and those words that he's fine and then he could drive and work normally 2 weeks later are still ringing in my ears. If I was to have a smartphone those days, I'm sure I would have taken his photographs. So sometimes I really feel sad that I don't have the photograph of my first patient. Anyway, the first ever laparoscopic cholecystectomy was a success story. Here I would like to admit to all of you that while doing masters in surgery and also while doing FRCS or working there for 5 years in England, I had not performed a single diagnostic laparoscopy. So when I had decided that I want to start laparoscopic cholecystectomy, I was naturally scared of putting the first various needle and the first blind port. And as you all know, if the first port is not inserted properly, you cannot proceed with the rest of the procedure. So inserting a safe entry of the first port was very important. So while I was awaiting to procure laparoscopic equipment, I regularly visited my gynae friend, Dr. Sanjay Bideye, and learned to insert the first blind port after the injury. Whenever he had patients for tubal ligation or for diagnostic laparoscopy, I would be there, I would visit, and he would teach me how to do that safely. So I think I would like to say that Dr. Sanjay Bideye has a great share with the success of my first laparoscopic visit. For the first 5 operations of lap hole, I could not sleep very well on the previous night. Thinking about the surgery that was planned next day morning, the thoughts of how the gallbladder would it be inflamed, would there be lots of adhesions, would I be able to clip the cystic duct, because those days we didn't know how to tie. So if that was wider than my clip, you had to plan it, how to do it, apply partially cut it, apply leave. So all those thoughts used to crowd my mind on the previous night, and they wouldn't allow me to sleep. It was as if someone was going to take my exam next day. However, after performing 5 laparoscopic cholecystectomies, I started settling. Then I realized I needed to make sure that the common man knows about this procedure. Dr. Wilson only knows why I just looked at her. Okay? So the common man had to know what this new procedure was so that more patients could benefit from this new procedure. Those days, social media did not exist. So I wrote an article in Sakar newspaper, and in that I wrote in detail about what is a gallbladder, where is it in the abdomen, why do we form gallstones, various modalities of existing treatment, then conventional method of open cholecystectomy, and now the new technique of laparoscopic cholecystectomy. Its advantage learned a lot from that experience and got a new vision regarding surgery. After this advanced surgery, I realized though I had seen advanced surgery there, India was not ready for it those days. Another thing I realized that if I were to train surgeons to perform laparoscopic cholecystectomy, then I had to teach them on the pigs first. So after returning to Pune in September 1991, I started exploring the possibility and feasibility of starting animal lab. I went to a piggery to see if I could procure pigs for the animal lab. But when I saw those small, dark, dirty pigs which were covered with mud, I could not but stop comparing them with those robust, healthy, white pigs which I saw in Germany animal lab. I talked to the owner of the piggery. He was ready to give me one pig for rupees 500. I requested him that after finishing the surgery on the pig, he should take back the pig. And I also requested him that he should not immediately sacrifice the pig because in case there were some drugs in the body, he should allow them to get rid of them. The owner was happy that he could lend the pig to me for rupees 500 and also have it back. And I was happy that the owner was ready to take back the pig because I didn't know what to do with that life because the surgery was over. So this was a very win-win situation for both of us. I requested my friend Dr. Shubhata Kharshikar, who is an anesthetist. 45 minutes, who is an anesthetist for human beings and not a veterinary anesthetist, to anesthetize the pig and keep him under control till the operation was over. We created 2 rooms on the ground floor of our house by enclosing the car park area. One was an operation theatre and other was a service room. I equipped the OT with hydraulic table, OT lights, laparoscopic trolley, and everything. I used to transport the pig from the piggery in a gunny bag, making sure that the nostril of the snout of the pig was out through one of its tiny holes so that the pig could breathe while it was being transported. I would tie the front and the back legs of that pig as well as the snout for the fear that something would go wrong. And then I would also give an injection of a mixture of poultry and phenylalanine so that the pig would be drowsy while it was being transported. Thus, the pig would be transported from the dicky of my Maruti 800 from the piggery into the OT which was created in the parking lot. And while the pig was still sedated, we would untie the legs and tie all the 4 legs separately to the operation table. Those days, I could not get a laryngoscope with a long blade like I had seen in Germany. So I used to make a small tracheostomy and pass it into the tube, and then my anesthetist friend would manage it. We also used to give an antibiotic and a painkiller to the pig. Once the surgery was over, again the pig would be tied, hands would be tied, front and back legs, and then put in the ventilator. This animal lab, which I started in February of 1992, was the first of its kind in India, and I ran it regularly till 2000. This monthly weekend course of laparoscopic training in the animal lab was a regular feature for almost 9 years. Usually, the batch would consist of 4 surgeons. 2 operations would be done on a Saturday afternoon and 2 on Sunday morning. And out of 4, 1 would be the main operator, the second person would hold the camera, the third would be the assistant, and 4th would be on the trolley handing over the instruments, picking up the clips and everything. Then during the second operation, they would rotate, and I could see by the end of 3rd and 4th operation, the coordination was far better, and I would try not to wash so that they could do the operation themselves. Besides these operative sessions, I would show them the recorded videos of actual lab cholecystectomy on patients, and also give them information about what are the instruments, who makes them, where to buy them, what is the cost, and everything. I did have a teaching attachment in Pune, but this was my teaching attachment created by myself because I was very eager to teach. This animal lab gave me this opportunity to teach surgeons, and while teaching them, I also learned many things from those surgeons. Here, I would like to share one interesting experience I had with the pigs. On one Sunday evening, after having the second session of cholecystectomy on the pig, the pig was put back in my dicky of 8 months and I was returning to the pigs. On the way, I had to see one patient in another hospital. So for a few minutes, I got down from the car, saw the patient, came back and sat in the car. About 5 minutes of driving the car, I suddenly saw face of the pig in my rear view mirror. And that really scared me. What must have happened? Probably while I had got down. The sedation effect probably was because there was a delay between finishing the surgery and then we had to go and see the patient. So I didn't take them back immediately. So maybe the sedation was over and he must have come out of the van and was standing in the DP. And as you all are aware, the Cochlear DPs are open tight. So I thought he would easily jump and come out of the rear seat. And that really made me so scared. This fear thought was itself scary. I accelerated the car. And at the time I reached the figure I was supposed to reach. My work in laparoscopy and my eagerness and enthusiasm in teaching surgeons, other surgeons, was appreciated very much by Mrs. Sybil Stoss, who is the owner of the Stoss company. And in that appreciation, she presented me a full set of laparoscopic equipment, including the camera, everything. Because she said you should use this system and you're spreading it and you're making people aware. So I think this was a great gesture on her part and I was really touched. Myself and my husband, Dr. Sanjay, we were busy with our own branches and our practices. We both were mobile surgeons. I would carry the laparoscopic equipment in my car and Sanjay is urological in his. We both would render our surgical services to patients at the doorstep of other hospitals. In fact, Sanjay was traveling to almost 50 to 60 hospitals in Pune and around. But then a time came when the traffic started becoming busy. Still, I would say, compared to what it is today, much less, but it got busy. And we decided that in order to stop this hectic traveling, we need to have a small but our own hospital set up. So on 1st of January 1995, our own T20 Endosurgery Institute was started. It was inaugurated at the hands of mine and Sanjay's parents. We knew how to perform surgery, but we didn't know how to run a hospital. But over a period, we learned that. Here again, I would like to share with you that from the day or from the start of the hospital day till today, and it will go on again with further, we have not refused a single patient who belongs to our branches. Either I can do justice or Sanjay, just because the patient has no money or less money. And we are very proud of that. Also, the patient is likely to benefit from laparoscopic procedure. I have never offered open surgery just because the patient is going to pay less. Because I think more than a well-to-do person, manual laborer needs laparoscopic surgery because that person is the wage earner. A wealthy man can take rest because his income is not affected. So more the reason why I've had Maushis and those social people, their daily wages are very important. And once whatever we agree to, suppose they don't have money, whatever they pay on the initial listing, and then later on they are very honest compared to the well-to-do people. They their promise that they pay 1,000 rupees per month. They will make sure they come back and pay that. And tears come to my eyes when I see all those things. Sometimes when I said, okay, the last 5,000 go to give me. It's okay. So that 1,000 is also very important for me. So I don't, neither me nor Sanjay, we want to be doctors of wealthy people. We want to be doctors of every person who needs our facilities. So we call ourselves modern. Take it from the rich and give it to the poor. Somebody can afford to charge normally. Don't charge excessively because he's rich. But somebody cannot afford, don't sell him or her back. Because I always feel I've been lucky, my parents have given me education. As I said, we were not very well, middle class family. Luckily, some skill in my hands, and God has sent me a patient. So what is my job? Use my skill, do the surgery. How much he or she pays? There is always never a loss. There is always loss in the profit. You are never negative. Instead of 10, you may earn 2. It doesn't matter. But you have made somebody better, what he deserves. And we have dissociated money from the medical treatment. How much money he can pay is decided by, we have one doctor who takes care of that. I just tell him that you have to do this, and then finances, I'm not sure. That doesn't mean I'm going to use inferior quality material. Same material will be used, same things will be used, because we don't want any complication. Me and Sanjay being of branches, we are so close. We are always having gun at each other, so that the patient doesn't get complications. The patient is good. Because I can understand what he has done. Surgery and urology are very close branches. So he can understand what I have done. So as I can criticize, we can also appreciate each other's skills. We can also criticize, and then we, as I said in the morning walk, we always have healthy criticism about what happened yesterday or what we are planning for tomorrow. So that we want minimum complications or the least complications in the patient. When somebody enters his or her life in our hands, we have no business to play with it. The day we feel that money comes first, we need money, everybody needs money, but how much money? There's a limit, okay? So the day I feel, okay, I have to go for some shopping, I have to go for going behind this patient is coming, I will stop operating, I will stop my practice. Because nobody forced it on me. I have become a doctor of my own. So I think all of us should remember this. This I can tell you. If somebody's life should have the least complications. What you would not like on yourself, which is not possible. So I think that is very important. We started the hospital in 1995, but I was still eager to learn new procedures. So I went to various places. 1996, went to Lama to learn laparoscopic laparoscopy. 98, we went to Los Angeles to learn laparoscopic hiatus hernia. Those days, harmonics culture was not available. So in hiatus hernia, as you know, along the greater curvature, you have to divide the momentum before you can go wrap. So they used to put clips because there was no harmonic. With harmonic and biopsy, has become a child's play. So clip, cut. So it used to take very long time. The procedure was very long and tedious. Now with the help of harmonic, like my grandchildren sometimes ask, when you were kids, there was no TV. So how did you spend your time? Okay? So similarly, now we are so used to
Sorry to interrupt, 5 minutes more.
Yeah, but today already? Yeah. So already actually the right. So I went to various places. I did lots of workshops, not only in India but also abroad. And there is always pleasure in teaching because when you teach, you also take back some message yourself. And we received these various awards for my pioneering work, which is Shishika Award given by the Mumbai Medical Foundation. Sanjay also was chosen as a BC Roy awardee in 2016. So we all went to Rashtrapati Bhavan, his brothers and my daughters. And these are the hobbies that I try to preserve in spite of a busy career. I love all these things and I don't like to miss my morning walk. So I think I'm a very proud and happy wife, a proud mother, proud mother-in-law with Vindesh and Chinmay as my sons-in-laws. And of course, the cream of the cream, I'm a very, very happy and proud grandmother with 4 grandkids. So while doing this multitasking, I think many people have helped me. My first teacher is Dr. Vayar, came from Naya Hospital. And what he told me is sit by the patient if the patient is not well. Clinical judgment is more important than any of the investigations. M.J. Joshi from Pune, Dr. Udvadia, Dr. Bharucha, Dr. Srikhande. And all these have played a very important role in my life. So have I my parents, my brother and sister, my in-laws, and 5 kids of Kulkarni family with all 3 brothers and their wives. We have 1 kitchen and we have the wardrobe today. The son is married and we have a daughter-in-law who also is with us and we are really happy about it. So what next? Next is we are building a 100-bed nephrology hospital which is almost ready. So by the end of this year we will shift to that place. And why a 100-bed hospital today at this age? Everybody was saying your daughter is there, she's not going to come back. Why are you doing it? This is because we already have for the last more than 15 years people coming from abroad and India for fellowships and for observership. And our place is not enough to accommodate all this. So we actually started looking for a place with a lift, but ultimately we ended up buying a little more and then also be 100-bed hospital so that we have DNB urology once it starts running. And the DNB so that there are very few 3 or 4 hospitals in whole of India with single specialty and nephrology. Most of them are part of a multi-specialty hospital. So one single specialty and then we will be able to have that. And I will continue my laparoscopic work in urology there because I've already doing nephrectomies and prostatectomies laparoscopically, so my work will continue. Thank you very much.
Thank you so much, madam. Everybody was so engrossed in the talk. I was very fortunate enough to watch madam doing surgery laparoscopic in 1994 in Pune Hospital. I was part of the team. And
I request our President Madam, Dr. Meenakshi Deshpande, to come on the dais to felicitate Madam. And all the chairpersons to join the felicitation. Yes. Dr. Ravindra Putte sir, you can also join. And Dr. Padma Iyer Madam.
First woman surgeon of the world for special felicitation. She is the first faculty of EVECON in Pune city because she is a resident of Pune and being the first woman laparoscopic surgeon all over the world. This was a token of appreciation for her that I could give her the first talk of EVECON. Mic you can have a mic of
Congratulations, madam. You have showed your journey in laparoscopic surgery. We are proud that I attended many of your workshops, and I am again seeing you on Pune Surgical Group. Congratulations.
What an excellent beginning of an EVECON. So they always say that whatever is well begun is half done. So I'm sure this EVECON is going to rock, and I must congratulate all the organizers of EVECON for that. So after this wonderful and inspiring talk by Madam Josna Kulkarni, now our next doctor is
It generates movement in the fluid-filled inner ear, known as the cochlea.
Dr. Gauri Betsare.
The cochlea is lined with thousands of tiny receptors called hair cells.
She was the one who started the Betsare ENT Hospital in 1994 in Vishrant Valley. This hospital offers advanced treatment of ear, nose, throat, allergy, and vertigo disorders. She is working as head of the department of ENT in prestigious Ruby Hall Clinic, Pune, since 2009. She is also honorary professor and director of School of Audiology and Speech Therapy and director Cochlear Implant Program at Bharati Vidyapit, Pune. She has dedicated her services for deaf-mute children, and she offers them free cochlear implant surgeries through central and Maharashtra government scheme since 2008. May I present to you Dr. Gauri Betsare. Good morning.
I'm grateful to the organizers of EVECON for having me invited here to talk about the topic which is very close to my heart, cochlear implant, a boon for severe hearing loss. So let us understand what is cochlear implant. It's an electronic device which converts sound signal to electrical impulses, which directly stimulates the fibers of the cochlear nerve. And how does it work? Let's see.
In order to understand how the implant works, it is helpful to have a basic understanding of how the normal ear functions. In the hearing ear, sound waves travel through the external ear canal and strike the eardrum, causing it to vibrate.
We have learned this.
This vibration creates a chain reaction in the three tiny bones in the middle ear.
Tympanic nerve.
It generates movement in the fluid-filled inner ear, known as the cochlea.
the
The
cochlea.
cochlea is lined with thousands of tiny receptors called hair cells. As the fluid moves simultaneously throughout the cochlea, the hair cells bend and trigger electrical impulses, which are sent to the hearing nerve. The hearing nerve carries these electrical signals to the brain, where they are heard as sound. Millions of people with sensory neural hearing loss or nerve deafness have damaged or depleted hair cells. If the damage to the hair cells is severe, even the loudest amplification from the latest digital hearing aids may provide limited benefit. To treat nerve deafness, the Clarion C2 bionic ear bypasses damaged hair cells and delivers stimulation directly to the hearing nerve. The system picks up sound through a microphone and transmits it to the sound processor. The processor converts the sound into high-resolution electrical signals, which are programmed specifically for each patient. The full broadband sound signals travel to the headpiece, where they are sent by radio waves through the skin to the bionic ear.
Puts it to the cochlear
The
nerve.
bionic ear delivers the signals to Clarion's electrode array, which directly stimulates the hearing nerve, delivering sound information to the brain.
So who is benefited? A person with bilateral profound to severe profound hearing loss, who is not benefited with any of the hearing aids and who has no medical contraindication for surgery. What are the components of cochlear implant? There is one external component. Though cosmetically it is seen, it remains outside the body and it consists of microphone, speech processor and a transmitter and an internal component which is fitted surgically inside the body. And the outside inside part is connected to each other by magnet. So at night they can remove the outside part and sleep. In the morning they put it again and they start hearing through it. Now with the new models, you can see it on that side. The outside part has become very small. The main problem is we cannot make a battery which can live inside the body forever. So that is why the outside part has a battery and now it is very small in the new models of cochlear implant. It is hardly seen, it is hidden in the hair. The incidence of profound hearing loss is quite a bit. Over 5% of world population, that is 430 million people require rehabilitation to address their disabling hearing loss. And may I mention here that there are almost 9 million children in India who suffer from profound hearing loss. Every patient with profound hearing loss should undergo cochlear implantation because they cannot hear, they cannot speak. So a child who cannot hear from birth cannot speak. So they have two disabilities now. So every child who has profound hearing loss should undergo cochlear implantation followed by auditory verbal therapy to develop good speech, and this can really make them lead a near normal life. A successful cochlear implant program needs a strong team of trained ENT surgeons, pediatricians, audiologists, auditory verbal therapists, motivated parents, funding agencies to achieve good outcomes. What are the options for a profound hearing loss patient? One is sign language. Second is to use the damaged hearing apparatus with the help of hearing aids. Whatever hearing they have can be augmented by taking a strong speech therapy, but you can hear. It is hardly understandable. With whatever damaged hearing apparatus they are using hearing aid, and the speech quality is really poor. And with cochlear implant, so I have already mentioned about the team which is required to perform a successful cochlear implant, to conduct a cochlear implant program. What is the role of ENT surgeon? He should have knowledge to manage a deaf child. He should know different steps of rehabilitation. He should interpret the audiological workup. He should know what is
the radiological workup of a cochlear to be cochlear implanted patient. He should be able to counsel the parents and do the general assessment of the child and the family. He should interact with pediatricians, psychologists, hospital management, cochlear implant dealer, fundraising NGOs, and of course, he or she should have a good surgical training. The audiologists are very, very important because they are the ones who will help us to do the early identification. So they will do it by doing OAE test. So let me stress this again. OAE is autoacoustic emission, and this test can be done in 2 minutes in a newborn child or even on day 1. This tells you pass or fail, means whether the child is hearing or the child is not hearing. If the child is not hearing, then we should do the BERA testing, brainstem emotive response audiometry, which also can be done within few months of after birth. So once it is established that the child has hearing loss, definitely there is very early intervention and they really do well in life. Speech therapist or auditory verbal therapist not only assesses the speech of the child, later on they are very important in giving the speech therapy so that the child can really speak age appropriate. A pediatrician is important for assessment of milestones and the vaccination. How early we can do implant? Even less than 1 year of life. Whether unilateral or bilateral, ideally bilateral. What is the preoperative assessment? Audiometry, OAE, BERA, radiologically CT scan and MRI, and overall assessment. I've just put the surgical steps. It's a highly edited video, but I'll just show you the end part of it because of lack of time. Anyway, it's not running. I have to see if I can show you. It is just like any other ear surgery. It is done under general anesthesia. It takes around 2 to 3 hours. And the implant is put after doing the cortical mastectomy. And in the receiver bed, you put the receiver part and the electrode goes in the cochlea. So this is how it is done through round window. So if you remember, oval window and round window, these are the 2 windows to the inner ear, and it is put through the round window. So post cochlear implant, after 15 days, the implant is switched on so that that person hears for the first time in his life. It's really a special moment for the family. And then the therapy starts, which goes on 2 times a week for next 2 years till the child speaks normally. So this is post op. I hope this goes well. Anyway, this shows this video was post-operative video of parents and the child showing how the child has started babbling after doing the implant. Coming to what is important is what is the cost of implant. The cost of implant is 6 lakh rupees. The surgical cost and the pre-operative evaluation takes around 1 lakh. So totally the whole cost of that whole process is around 7 to 8 lakhs. And of course, fundraising is really a problem. And I started cochlear implant program, and because of that, I started School of Audiology and Speech Language Pathology in WDW in 2006. We started cochlear implant in 2008, which was totally privately funded by the patients, by the companies, by the NGOs. But I'm very happy to announce this that in 2015, central government, Modi government started a scheme which is called as ADIP scheme, ADIP scheme, which funds complete cochlear implant to a child till the child speaks. So only pre-operative investigations are done by the family. They have to spend around 25,000, maybe maximum. even that can be reimbursed. But this implant is given by central government. We are one of the 100 centers in India which are recognized under aid scheme at WDW. And any patient who has hearing loss who is less than 5 years of age, who has income less than 20,000 a month, which is also not very low, get complete funding for cochlear implant. So government sends cochlear implant, the surgery is funded, the therapy is funded, even coming and going is funded. So very few people know this. So I really appeal to all of you. So if you identify, if you see any child who is suffering from hearing loss, who is less than 5 years of age, if you direct them properly, they can really, hear well with the implant and speak well. Now I'm going to just touch about adult cochlear implants because we are doing adult cochlear implants. This photo, I hope the video runs, is a lady who was working as a principal in some school in Sangli, and she was wearing a hearing aid. Family has history of hearing loss, and suddenly she lost complete hearing. And 10 years of her career was remaining, and they came to us. We did implant for them, and she has joined back. I'm really feeling very sorry that I cannot run with people. Anyway, at least few videos done. We perform a graduation ceremony for children who have done implant with us and who have done therapy with us for 2 years. After 2 years, these children are ready to go to normal school, and we conduct a graduation ceremony for these children every year. So you can see this happy group of children with their parents, and really one can transform a life of a person who would have been otherwise disabled into a normal life. They go. I have a video again. I'm not sure that this will run.
Ma'am, you have 2 minutes more.
Yes. This was a girl who received the graduation award and was implanted, and she's telling her story, but I'm sorry about this technical problem. So anyway, so anyway, give me 2 minutes. So this is the institute where I got my training in Melbourne. I visited many places in US, Europe, and this was the one where I got training in cochlear implant. But that slide I always keep is, you can see 2 children, they are twins, they are bilaterally implanted, and this was totally sponsored by Australian government. This was in 2005, and I felt so bad that nothing is done in India for these children who are having hearing loss and cannot afford a cochlear implant. And that has come to a reality now from 2015. These children are supported by our government also. And I'm so happy that 3 years back, Pradhan Modi ji called 100 kids who were benefited under aid scheme. He wanted to make sure that this program is reaching people. And because of these 100 kids had to go to Delhi with their parents, he wanted to meet and ask them whether they are really benefited with whatever money government has spent is really reaching the people. And it's a huge teamwork. I want all of you to just copy this if you can take a photograph. Because we get references from Beed, Satara, Sangli, Nagpur, Amravati. I wanted to tell you, I want to aim at this story, with a story. Recently, last month, I had performed one tympanoplasty at my hospital. And this person said, I would have taken your help long back. I said, why? I stay 10 minutes from you, and in Bhairav Nagar, I have 3 children who are deaf. One is 22, one is 19, and one is 11. And I felt so bad. I'm just 10 minutes away from my hospital. It's 10 minutes away. I'm practicing there for 27 years. And I could not pass this message to this man. And he has 3 kids who are now a social liability. So I would request all of you to, put this message in the society that whosoever has hearing loss, one should undergo OAE and BERA. And there is help which is provided by central government. So money should not be a problem. Sorry, I could not show you the results. There were so many videos for children who are implanted. They are speaking well, they are going to school, they are having normal life, they are playing badminton. But sorry, the videos could not be some other time. Thank you very much.
Thank you, madam. Thank you so much. This was really an excellent presentation, and really you are doing a very good work. So I really bow to you, and I'm sure that all of us have taken this message to our IMA branches, and surely everyone is going to help you in this your endeavor. Thank you so much.
Now I request our President, Madam Dr. Meenakshi Deshpande, to come on the dais to felicitate Madam, and Dr. Vaijanti Patwardhan, Chairman, IMA WDW, to felicitate, and Dr. Prakash Marathe sir, Senior Vice President IMA to join the felicitation. And I request all the chairpersons to join the session.
And I feel proud to say that you have done excellent work in this field. And I hope this goes to many people all across the state, because the message she has given has got a lot of social implications.
Thank you, madam. Now I request Dr. Vaijanti Patwardhan madam to felicitate all the chairpersons and Dr. Prakash Marathe to join. Dr. Vaijanti Patwardhan madam, Dr. Rohini Padwe. Dr. Marathe sir, Dr. B.S. Deshmukh, and Dr. Meenakshi Deshpande. Thank you, Chairperson, for conducting such a nice session. So now we'll be going to the further session, panel discussion on research and management in breast cancer. To moderate this session, I invite Dr. Anupama Mane on the dais as a moderator. She is a MS General Secretary from Government Medical College, Meerut. She has trained in breast surgery from Tata Memorial Hospital, Mumbai. Second one in breast surgery from Interdisciplinary Breast Cancer Center, Düsseldorf, Germany, and the European Breast Cancer Network Program. Trained in orthoplastic and reconstructive breast surgery from Royal Bradley Hospital, UK. So, I have along with her our other panelists, Dr. Varsha Hardas madam. She is a senior consultant in charge of breast imaging, Union Clinic and Brand Medical Foundation in Pune. She is got a special area of all features, breast imaging, DBT, PhD, MRI, and all interventions. Dr. Mansi Munshi from Union Clinic, breast and gynecological prostate cancer, cancer genetics, hereditary and cancer. They are her special interest. And Dr. Nanda Kachare, she is a consultant histopathologist and head of department of histopathology, Vidyanath Clinic. 19 years of experience in surgical oncopathology. Previous work experience at Kochi. And Dr. Chapur Vora is a medical oncologist and hemato-oncologist at Vidyanath Clinic, Neonatal Cancer Center, Pune, and Sasu General Hospital, Pune. He is DM in medical oncology, MD in general medicine. So over to Dr. Anupama Mane madam. You can start, madam.
Thank you very much. A very good morning to all the lovely ladies and gentlemen sitting here.
Thank you very much to IMA for giving us this opportunity. So, as you can see, we are all working with the Ruby Hall Breast Center, and this is our team. Everybody here on the dais. And what I want to actually stress in this panel discussion, through case discussion, is actually breast cancer treatment now is no longer mastectomy or a lot of chemotherapy with hair loss and radiation with a lot of side effects and all. No, the breast cancer treatment has changed over the years. And now it has become very precise, conservative, less surgery, less chemotherapy, good results, and long-term survival. Ultimately, we are looking at survival for these patients. So how do we do that? How do we integrate everything and give the patient the best result possible? So we are going to be discussing with the help of two cases actually. These are routine cases which might be coming to your OPD. The first one is a 50 years old lady, postmenopausal, came for screening mammography 1 year ago. And why she came for screening was because her mother had been diagnosed with breast cancer 1 year back. So she thought she should also get herself checked up. So she came for a mammography. She had 2 children, breastfed, and when she did the mammography, there was nothing abnormal as such on the mammography. But on sonography, something was seen. Can I ask Dr. Varsha to explain what this is? Such a small little tiny thing, if you can, see this over here.
Yeah, hi, good morning everyone. So these are the ultrasound images of this young lady who has positive family history. Her mom was just recently diagnosed. So when we see something as small as this, it is important for us to make a note of it and keep a follow-up. So this was actually looking like a very small benign adenomatous or a small adenoma. It didn't look suspicious at all at that time. Mammogram was normal, but ultrasound picked up this small nodule. Of course, it was not palpable. So we had advised her to be on a follow-up, just keeping in mind that she has positive family history. So we had given this as BIRAX 3, and I have asked her for follow-up after 6 months.
Yeah, so she didn't come after 6 months because of COVID. She came after a year with again some vague complaint of heaviness. And on clinical examination, everything looked normal. And then the mammography again obviously was repeated. It was more than a year. And the mammography showed something a little abnormal. So can you explain?
Yeah, so these are her mammogram images. Normally, mammogram is an X-ray. As all of you know, we take 2 views of both the breasts. One is CC and the MLO view. Here we can see on the left side, on the CC view, we didn't see anything, but on the MLO, we are seeing a very small density. The same adenoma which we had seen before on ultrasound was now evident on the mammogram. Now these are her just 2D images. Now we also have something new that is a 3D mammogram, that is a tomosynthesis. So when we scrolled the 3D images, what we saw was very fine. Can we have the other image? Maybe you have an image? Okay. So we don't have the image now, but what we saw on the tomo image is that was a very early speculations that were seen in that region. If you can point out from the pointer, then
that is the lesion over there.
The pointer is not seen. We have a physical computer. If we have a pointer, we can point out. It's a very, very subtle finding. Now, these are the kind of cases which can get missed if we are not very careful and if we don't have a tomosynthesis. But because of tomosynthesis, we could check that there are very early speculations. And then once we see the speculations, this becomes very suspicious. It was around 7 millimeter, I think. And we, of course, wanted a biopsy. We saw it again on ultrasound. Again on ultrasound, the adenoma had just increased by 2 millimeter, but there were a little speculations, early speculations. So we advised for a biopsy for this particular lesion.
So basically, this finding could be picked up only because of the 3D tomosynthesis that was there. The technology that could pick up such a small little suspicious lesion. Usually, with the 2D normal traditional mammography, this would have been missed completely. So biopsy was done, obviously ultrasound guided, and you can see that that is the core biopsy needle going into the lesion under ultrasound guidance. And we got the result as positive for malignancy, infiltrating duct carcinoma. And obviously we had to plan further for treatment. But before going on to that, I asked Dr. Nanda, why biopsy, why not FNAC? I'm sure many of us are doing FNACs also for breast lumps. So why not to do FNAC?
Hello, good morning, everyone. To the answer to your question, usually this was a training that for any palpable lump or non-palpable lump, detected lump, first do FNAC and get the diagnosis and then proceed further. But now the changing trend is that FNAC is not recommended for the diagnosis of breast malignancy per se, or any for that matter, any breast lesion, because with the FNAC you do aspirate the material, which gives you only psychological diagnosis or the psychological information and not the complete diagnosis. With the USP guided biopsy, we do directly target the lesion and we have more chances of getting accurate diagnosis. With the biopsy, we have more chances of doing further additional immunohistochemistry tests on the biopsy, which will help us to identify the hormone receptor status of the patient if it is a malignancy. So the most important advantage of doing biopsy is to know the hormone receptor status of this patient in case of malignancy, and that is why which has treatment implications. So always the breast USG guided breast biopsy is recommended and not the FNAC.
Right. So in other words, if I can tell you, sensitivity or the accuracy of FNAC is only 70% in breast malignancy. That means in 70% cases you get the correct diagnosis, 30% it will be missed. Whereas with a core biopsy, it is 100%. 100% accurate result you are going to get, especially if it is ultrasound guided, because it is image guided. Sometimes what happens, the surgeons do the biopsy themselves, feeling the lump. But if the needle does not go through the lesion, it is not ultrasound guided, then you get a wrong report. You get a false negative report. So I would recommend ultrasound guided biopsies for all breast lesions. So now going on further, this lady had a malignant lesion, very, very small. The lymph nodes looked negative. So she underwent surgery. Now, surgery was a wire localization. Why a wire localization? Because, we could feel the lump. We didn't know where to remove. So, as a result, again, the patient was sent back to the ultrasound department under local anesthesia. Ma'am, can you describe wire localization?
Yeah, so this is the procedure we commonly follow because for small non-palpable lesions. And it's always a teamwork because whenever the lesion is not palpable, the location is not very sure, the surgeons definitely cannot go blindly and remove a lot of tissue from there. Even if you report that it is at 12 o'clock, that means if it is not accurately targeted or wire localized, they will just have to remove a lot of normal breast tissue as well. So what we do in such cases is that under image guidance, we introduce a wire just prior to the surgery. We introduce these wires are all available in the market, but it has to be done under ultrasound guidance so that we know that the wire has gone through and through the lesion. And then it becomes very simple for the surgeon. We send these patients back to the OT right away in that with the wire in position. And the surgeon, it becomes very easy for them to only remove that area. And sometimes when there are calcifications associated with these lesions, they send the specimen back to us to confirm whether whatever they have removed, entire pathology has been removed. So we do an X-ray for that specimen as well, and let them know whether the surgery is complete and the lesion which we are targeting has been completely resected or not.
So on the histopathology, it was invasive ductal carcinoma, very small size. You can see the tumor size being 0.5 into 0.3 centimeter. I mean, it was not even 1 centimeter. All margins were free. There were 3 nodes we had checked by sentinel node biopsy. They were all negative. So she did not need a complete axillary dissection. She did not need a mastectomy. Her surgical procedure was complete. There was no cosmetic deformity. And she had a very good report. The estrogen progesterone receptors were more than 90% positive. They are a prognostic factor. So very good. HER2 is another factor which is checked. Prognostic and predictive, which is negative, which is again a good report for her. And Ki67 is a proliferative marker, which was also very, very low. So, Dr. Chakor Vora, our medical oncologist, if this patient came to you with this report, what would you recommend further? She's a postmenopausal lady.
So, considering this histopathology report and a small tumor size with a very low Ki67 and strong hormone positive status of this tumor and HER2 negative status of this tumor, this patient, I'll just advise adjuvant hormone therapy to prevent any recurrence. She per se does not need any chemotherapy or any targeted therapy from medical oncology aspect, because the recurrence rates in such kind of tumors are quite less. It's a small tumor with a good, all the prognostic factors as ma'am mentioned are all good. And chemotherapy will hardly benefit 1% or less in the long run. Even at 5 years or 10 years survival, the additional benefit with giving chemotherapy will be hardly 1%. So in such a patient, I'll rather skip or omit entire chemotherapy and refer the patient to a radiation oncologist.
So you can imagine the patient's happiness when she was told that no chemotherapy is required. You know, I think all the ladies are very concerned about chemotherapy side effects, especially the hair loss. So they are most happy. They are okay with surgery and radiation. They are most happy if chemotherapy is avoided for them. So she went for radiation therapy because no chemo was there. And Dr. Mansi, could you explain what radiation was given?
Good morning, everybody. So this lady, because she had a breast conservation surgery, she required radiation. Radiation has shown to not only reduce the chance of local recurrences in the breast, but it also translates into an overall survival. So radiation is extremely important for her. We did a whole breast radiation with a boost. And because it was a left-sided tumor and the heart is on the left side, we had to use some cardiac sparing techniques. So what we have at our center is something called as a deep inspiratory breath hold radiation technique, in which the patient takes a deep breath and holds her breath at a particular phase of respiration. And when this happens, the lung inflates and creates a space between the breast and the heart, and the radiation is delivered at that moment. Doses to the heart are almost negligible, and it's very, very safe to give it with this technique. There are some sensors placed on the body. So say the patient was to cough or to release her breath during treatment, in a fraction of a second, the radiation beam also is cut off. So for her, we did this deep inspiratory breath hold, and she tolerated radiation very well.
So again, this is a very advanced technique of radiation, DIBH, and very useful for ladies with left-sided breast cancer to avoid extra radiation going to the heart and the lungs on that side. So now, of course, this lady is on follow-up. She is just on hormone therapy, 1 tablet, that's all. And we just keep her on routine follow-up, nothing more. But what we wanted to share with you in this case was, first of all, screening. Screening is so important. When there are no symptoms, still a lady goes for checking and doing a mammography screening, such small lesions can be picked up. Now, this lesion would not have been palpable for at least 2-3 years, growing slowly. And she might have come later when it was 2-3 centimeters or more, and then all the treatment would have been required, chemotherapy and lot of radiation and other things and side effects. So picking up such a small lesion with good technology and people who are trained to pick it up at such stages, it can change a woman's life. And a woman's life saved is actually the whole family's life saved, because she's the fulcrum of the whole family. So this makes such a lot of difference to so many people, for the lady patient and for others. So screening, actually in India, we don't have a routine cancer screening program, but what is recommended is after the age of 40 years, start with a baseline mammography, And if there is no family history, no other risk factors, once every 2 years till 50 years, and once every year, annually mammography to be done after that. From 50 to 70 years, after 70 years, we stop the mammography screening. And in case a patient has a family history of breast or ovarian cancer, then we start the screening 5 years before the patient's relative had the cancer. So if the patient's relative had the cancer at 40 years of age, we would start earlier. We would start at 35 years of age. This is the recommendation which is adopted in the Western countries. Since we don't have our own recommendation, we are following this currently. So I would really recommend you all in your OPDs to check the detailed family history of the patient, and if there is a history of malignancy, please advise them on this.
Hi, Anupama. Can I also say something?
Yes.
Varsha. So, as you mentioned that, screening is important, and because all the patients reach out to them first, it is very, very important that all of you are also aware of the benefits of the screening program. So always, there are a lot of questions asked by the patients that, oh, it is radiation, or maybe mammography is very painful. But that is not the case anymore because we have newer machines, newer technology, they're all digital imaging. The dose is very, very minimal, and it is not at all harmful to even do the mammogram every year as a screening protocol. As far as pain is concerned, the newer machines are very well designed. They have a very smooth compression, a very fraction, like only 4 seconds of compression. So it is actually not a very painful procedure, as is what thought by most of our patients and even the doctors. So this is also very important for all of you to explain it to your patients that mammography is essential. Many times also we get the recommendations from outside that because mammography is very painful, please screen them with ultrasound. So that is one more thing which I would like to get to all of you to let you know that actually ultrasound is not the primary screening modality. Mammography is the primary screening modality because we are picking up smaller cancers as we saw in this particular case, or microcalcifications which will only be seen on mammography. So mammography should be the first screening modality and not ultrasound. Thank you.
So let's go on to the next case. A 30 years old. So this is a very young lady, Nali Paris, married since 2 years, and premenopausal regular menstrual cycles, no positive family history. She came with a lump in the left breast since 4 months. Now, when this kind of a lady, young lady comes with a breast lump, the first thought that comes to our mind is a fibroadenoma or something benign and all that. You really don't think of malignancy because malignancy is associated with old age. But still, what I would say is please keep an index of suspicion. Any breast lump or any breast symptom, rule out malignancy, rule out malignancy, rule out malignancy. At any age, we have seen even 20-year-olds with malignancy. So anyway, she came with an ultrasound done outside. It suggested atypical fibroadenoma. Now, this is a very common issue that, a lump is there. You think, radiologists thought it would look like a fibroadenoma, but some atypical features, so they said, okay, atypical fibroadenoma. But again, there was no suspicion of malignancy on this prior report. So she was just sent for another opinion to the breast center. On examination, just 3 by 3 centimeter, left breast, upper inner quadrant, and one small single palpable node in the left axilla. There was nothing else at all. And then she was obviously sent for sonography. Now, being a 30-year-old, first thing we would do is a sonography, not a mammography. Even though Madam has just suggested that mammography is better for malignancy, but primarily for less than 40. And clinically, we are not suspecting, then we send for sonography. So first, the sonography was done, and Madam will just describe this.
Yeah, so again, as Dr. Anupama has mentioned that this was a young lady, palpable mass, ultrasound done outside. By and large, everybody thinks that it will be a fibroadenoma because it's a solid looking lesion. I was very thankful for the radiologist friend of mine who actually sent this case again for an expert opinion to us. Madam saw the patient clinically and she sent her for ultrasound. Ultrasound, as we have already mentioned, that under the age group of 30 with no family history, screening for a diagnostic purpose, ultrasound is the primary modality of choice. So when we did the ultrasound for this particular patient, we saw, of course, a solid mass lesion which looked very much like a fibroadenoma, but there were very subtle signs showing that there is a little margin irregularity. There was a small satellite nodule. When you look at the axilla, there was an axillary node which was a little enlarged with a thickened cortex. So all these things put together, of course, it didn't have any vascularity. But imaging wise on ultrasound also, I had a suspicion that this does not look like a typical benign fibroadenoma or a proliferative fibroadenoma. I am not ready to call it as an atypical fibroadenoma. I gave it as a suspicious malignancy, even though she was a 30-year-old. And of course, advised for a mammogram and a biopsy. So whenever on ultrasound, we have a suspicion of a particular lesion to be malignant, and then in those cases, even if they are 30-year-old, 35-year-old, we will subject them to mammography because mammography is going to add a little more information in these patients. So this was her mammogram. We did a mammogram again. On mammogram, no signs of a typical fibroadenoma. Very irregular mass. On ultrasound, it was solid. So definitely high suspicion, moderate, definitely a moderate suspicion for malignancy. Also, as you can see, her axilla, we can see an enlarged node. Now, with the fibroadenoma, we don't normally expect an enlarged node. This particular imaging, the ultrasound as well as mammogram showed that there was a mass with an axillary node. We call it as Barrett's 4 and we advised for a biopsy. So this is her image showing the needle which is going through the lesion. Absolutely inside. So we know that we are not missing out because many times with big breasted patients with lesions which are palpable but they're very deep. So if you do a blind biopsy, you may miss the lesion. So image guided biopsy is very important. So we did an image guided biopsy and sent it for histopathology.
So this was the pathology report. It was an infiltrating ductal carcinoma grade 3. Ki67 was 70%. This is a proliferation marker. So 70% is considered very high. That means it is an aggressive tumor. Estrogen receptor was 10%, which is considered very low. And progesterone receptor PR was negative, HER2 was negative. So overall, this report did not show this to be a very low grade tumor. It was high grade and it was an aggressive tumor, and this was a very young lady. Nulliparents who also wanted to have children. I mean, she got diagnosed with malignancy, but because she would need chemotherapy for her aggressive tumor, she didn't want her ovaries to suffer. So there are these aspects to consider in these young ladies. First of all is genetics, and second is fertility. So Dr. Mansi, what can you tell us about genetics in this patient? What would you do?
So for this lady, she is obviously too young to get breast cancer. She's 30. And she has a family history of breast cancer, and it looks like it's a multi-centric.
She has no family.
Oh, she's sorry. She doesn't have family history, but she's very young. She's just 30. There were 2 lesions, so like a multi-centric satellite nodule. So she definitely needs a genetic evaluation done. What I would recommend is for her to undergo genetic counseling, in which all the information is given. Now, even though there's no family history, it could be the first case in the family, a de novo mutation, or sometimes the mutation could be passed on from the maternal side. So men, you may have heard of a gene called BRCA, which became very popular because of Angelina Jolie. It's basically an autosomal dominant inheritance. It can pass on from each generation to the next with a 50% probability, and there's no gender father can pass it on to a daughter and a mother to a son. So if it's coming from the father's side, and men usually don't have a high risk of getting breast cancer, even if they have the mutation. So it's not necessary that there will be a family history. She should definitely undergo genetic testing. It will impact her treatment as well as her reproductive choices, and it would also help her family. So there are a lot of things, but having said that, doing genetic testing in a 30-year-old also has a lot of psychological impact. So there's a lot of psychosocial aspects that have to be dealt with. Also the right time to give her the genetic counseling. So if you're telling a 30-year-old that you were planning to start a family, but you have breast cancer, and your next several months will be the breast cancer treatment, she is not really going to be in a very great frame of mind. So there is a cooling off period that we allow for the patient to kind of accept what is happening, and then we will do a genetic counseling for her and take it forward. But the implications are huge on herself, on her treatment, on her surveillance after the treatment, so that she doesn't get new cancers like ovarian cancer, for her siblings, and like I said, for her family planning as well.
So basically, genetic evaluation is a must for this patient because it can change her treatment as well as it can affect her family members. So now for genetic evaluation for testing, the report takes almost 4 weeks to come. We can't wait for 4 weeks to start her treatment. So how do we manage that? How do we cover that? That is by starting her chemotherapy first, because chemotherapy comes in cycles and we can get the adequate time, send a blood sample, get the report, and then adjust her treatment. Her surgical treatment is affected by her genetic report, testing report. So we delay the surgery for her, we start her on chemotherapy first. Also, if you notice, this lady wanted fertility preservation. So fertility preservation is such a young lady. Many of you are gynecologists over here would agree. Oocyte preservation. I don't know much about ovarian preservation, but yes, we refer to the oncofertility expert, and they do the oocyte retrieval. And she has a partner, she has a husband, and they would probably freeze the embryos and everything. So that requires time. We need 1 to 2 weeks or 3 weeks to get all this organized, but we don't have time to wait. She has an aggressive tumor, so we start all this simultaneously. And there are certain techniques, even during chemotherapy, that can help in ovarian preservation. Dr. Bora, what can you do during chemotherapy to preserve her ovarian function?
So, as we all know, chemotherapy can cause infertility in around 5% of the patients in due course of time. So, in such patients, what we many times do is ovarian function suppression with the help of either leuprolide or with degarelix. And that we start usually just prior to the first chemotherapy, so that the impact of chemo on fertility is minimum. So that's what we did for her as well. She being almost triple negative, her estrogen receptor was very mildly, like weakly positive, progesterone receptor negative and HER2 negative. So we gave her, treated her with entire chemotherapy protocol with 8 cycles of dose-dense AC protocol, that's adriamycin cyclophosphamide. So I'm saying dose-dense because the same chemo which we give at 3 weekly intervals, we give it at 2 weekly intervals. So we decrease the intervals between the chemotherapy to increase the density or the strength of the chemotherapy, and it has been proven that dose-dense chemo protocols are more effective as compared to the routine chemo protocol. So we gave her 4 cycles of dose-dense AC and then dose-dense paclitaxel and carboplatin. And to minimize the effect of chemotherapy on ovarian function, we gave ovarian function suppression. In short, we just put the ovaries into sleep mode with the help of hormonal therapy. So that's how we gave her the neoadjuvant.
So before the neoadjuvant was started, there was another step that needed to be done, because giving neoadjuvant surgery, giving neoadjuvant chemotherapy, that means before surgery, the tumor is likely to shrink completely with the chemotherapy. Later on, at the time of surgery, we may not have any palpable tumor at all, or even palpable node. So how do we remove it? So what we do is something known as ultrasound guided clip placement. So these are images. Dr. Varsha will just explain what was done.
Yeah, so all these patients who are mainly triple negative, who are going to undergo neoadjuvant chemotherapy, we know that the tumor can shrink, and especially triple negative cancers can actually vanish. So for that reason, it is very important that we clip them. Now there are 2 aspects: either we can clip them when we are doing the biopsy itself, or once we know that it is TNBC and they are going to start a neoadjuvant therapy, we will clip them. Why clip them? Because she's later on undergone a breast conservative surgery. Now, the surgeon should know where the tumor was if it has vanished completely. So these clips are available in the market. It's a simple procedure like a biopsy. We just introduce the clip into the lesion. We try to do it maybe at the first or the second cycle, because beyond that, I think the tumor starts regressing so fast that we have sometimes had cases where even on imaging or ultrasound, we could not detect the lesion at all. Only the clip is seen. So we clipped her. We also clipped her axilla because it was only one node which was suspicious. The rest of the nodes were looking normal. So because Dr. Mane wanted to do less like a limited axillary dissection, so we also clipped her node, and these are the images for that. You can see the epithelial clip inside the lesion, and we can also see the clip in the axillary node. It's a small clip.
So after she was put on neoadjuvant chemotherapy, after 4 cycles, we do a reassessment to see her tumor, how much it is regressing. So this was the reassessment after 4 cycles. You can see from the previous images how much the tumor has reduced. The node is also reduced. Okay. Again, we continue because she needed 8 cycles, so we continue with the chemotherapy. And then when we take her up for surgery, we do a mammography again. And sonography, you can see the clip over here on mammogram, the clip over here on mammogram, the breast tumor, and the clip in the axillary lymph node also. So this is what is going to guide us during surgery as to where to go and what to remove during surgery.
So if you remember the previous image of a big, more than 3 centimeter lesion, after chemotherapy, it's regressed to almost 5 millimeters. It's disappeared completely. It's only the clip that is seen on this.
So, this is one more point I wanted to make. Giving neoadjuvant chemotherapy, that is giving chemotherapy before surgery, is so useful. It helps us in finding out the response of the tumor to chemotherapy in vivo, in the patient's body. We know that she's responding well. In many cases, what surgeons do is just operate. The patient comes and they operate, and then you give chemotherapy. So you have no idea whether the patient is responding, not responding. So ultimately, that is to the detriment of a patient who is not responding to the chemo. Unnecessarily, you are just piling on the chemo. It's always a good idea to start neoadjuvant chemotherapy first, assess the tumor response, and then go on for surgery. Because you will give her a smaller surgery, better cosmetic results, and know how she's going to do later. If she responds completely, she's going to do very well in future. If she does not respond completely, she has a risk of recurrence, and then we manage that risk of recurrence immediately, to prevent it. So there is a lot of information we get by giving neoadjuvant chemotherapy first. So this was the same after finishing her neoadjuvant chemotherapy. You can see the tumor has regressed, the node has regressed so much. Now again, because there is a clip inside, a wire localization has to be done under ultrasound guidance. So a wire was put guiding to the tumor, and accordingly it was removed. The tumor was resected. And she underwent breast conservation and sentinel node biopsy after all her neoadjuvant chemotherapy was done. So her breast was conserved, her axilla was also conserved, axillary morbidity could be prevented. I'm sure you've seen a lot of your patients, lymphedema, they always keep complaining of lymphedema, arm pain, inability to move the hand arm completely upright. So all these things can be prevented if only the treatment is planned in a proper manner, and the lady should be spared a lot of morbidity and improve survival. So 5 minutes more. Okay. Sorry. Yeah, no problem. So this was the wire localization image. You can see over here the clip is there, and this was the resected specimen image. Once the specimen is resected in the operation theatre, it goes again to mammography department. And you can see the clip over there, the wire over there, which is guiding us, and all negative margins all around. And this is the lymph node, which is clipped, which is out. So this is to confirm that we've removed the correct thing, confirm it on mammography, and then send it to the lab for frozen section. Dr. Nanda, can you tell us something about the frozen section? Why is it so important to know the margins?
Okay. The frozen sections of breast conservation surgeries is a very routine practice which we see in surgical oncology. This frozen section margin assessment is very important to see the negative margin status to assess the completeness of the surgery, even in the primary breast as well as the post-neoadjuvant, where we can assess during frozen intraoperative assessment, and the no tumor on the ink once we have inked the specimen of intraoperative assessment, and all the margins should be assessed. So to see that there is no ink on the margins.
No tumor is remaining behind basically. So we routinely do a frozen section to assess that. So on the final histopathology, the report said multiple scattered foci of invasive tumor, but the largest was just 1 millimeter in that specimen. And out of 8 nodes, sentinel nodes, none was positive. And this was again reduced. The primary tumor was reduced to this. So you can just see some microinvasive tumor foci were there, but otherwise she had an excellent response. So we will call it almost a 99% response. Maybe 1% was remaining. So Dr. Vora, can you do something for that remaining? What does that remaining 1 millimeter mean to us?
So actually 1 millimeter is too small and it's near pathological complete response. So I say it's an excellent response to the neoadjuvant chemo. But in 2019, there was a trial which was published, a multinational multi-center trial, CREATE-X, done especially in the triple negative breast cancer population. And there it was shown that patients who have achieved a complete response, not even 1 millimeter tissue remaining, those patients we can observe safely. But if a PAC-CR is not achieved, then adjuvant capecitabine for the next 6 months, tablet capecitabine chemotherapy should be given for 6 months, and it showed overall survival benefit of around 7% at 5 years, and disease-free survival or recurrence-free survival benefit of around 15%. So just by giving tablet chemotherapy for 6 months more, we can decrease the recurrence risk by around 15% in the 5 years of follow-up next.
So this is what I was saying, that if these patients are operated upfront and then chemo is given, you will never know whether they will have residual tumor or not. So you cannot give this patient a benefit of tablet capecitabine. Only if you do the neoadjuvant therapy first, operate later, check out the pathological complete response. Can she get the benefit of capecitabine? So these small things matter. Ultimately, it all translates into better patient overall survival. So next she was sent for radiation therapy because she had undergone a breast conservation surgery. So Dr. Mansi, could you tell us quickly, please?
I won't go into too much detail because I described the radiation earlier. She received standard radiation. When lymph nodes are positive, we also have to radiate the supraclavicular area because that's the next technical nodes. So that's the only point I would like to add in the nodal radiation.
And after this, because she was ER positive, she was put on tablet tamoxifen, which she would have to continue for actually ideally 5 to 10 years. But as I mentioned to you, she is desirous of a pregnancy. So minimum I would say is 2 years, 2 to 3 years, and then we will reassess her regarding her tumor recurrence and then decide whether she can safely go ahead for pregnancy or not. And of course, regular follow-up will be kept. So the point I wanted to make from this case discussion is that every patient surgery is not the first option. Evaluate carefully, have a good radiological backup with you. Decide how to go about the case. Chemotherapy is so important in reducing the tumor. Surgery can be minimally invasive, does not need to be a radical mastectomy. Women can have a good cosmetic result and a better survival even with minimal treatment. Now, seeing all this, the role of radiologist, the pathologist, the surgeon, medical oncologist, radiation, genetic specialist, rehabilitation teams, all that is integrated together to provide the best treatment to the patient. And you might feel that all this seems like very high-end treatment, but believe me, it is not a very costly treatment. And in our breast center, we have special protocols for patients who are not affording. Even they are given this best treatment. And we have NGOs and CSRs and our medical social workers help in funding the treatment of these patients. But for the lack of money, no patient is denied all this high-end, technically specialized treatment. So we request you to keep all these points in mind the next time the breast patient comes to you. And I hope she'll be very happy with the breast treatment available. Thank you so much for your kindness.
Thank you, madam, for cooperating us for the time management. Now I request Dr. Dilip Sharma sir, our senior member of IMA, to come on the dais to felicitate our panelists, and Dr. Raju Varyani, President-elect. Along with Dr. Meenakshi Deshpande, madam.
इकडे समोर थँक यू.
Thank you, madam. Thank you, sir. Dr. Dilip Sharma sir. Thank you very much. Past president, I am Maharashtra State, and he is our I am a Pune trustee. With this, we will go to the next session. Gynec endoscopy boom for women's health, and the speaker is Dr. Manish Machwe. To chair this session, I request Dr. Prakash Marathi sir to come on the dais to chair the session. Sir is a consultant ophthalmologist, Netra Yogi Eye Clinic, Garvinagar, Pune, Senior Vice President, IMA Maharashtra State, and he is a CWC member, trustee and past president of Indian Medical Association Pune and Pune Ophthalmology Society, trustee and past president of Pune Ophthalmology Society. Yes. Dr. Madhuri Rao, please come on the dais. She is a consultant ophthalmologist at Cityside Eye Care and Paper Center, Varanasi since last 20 years. She is a secretary WDW IMA passion for social service. Yes, welcome, madam. Dr. Nandakishore Mantri, he is a family physician practicing at Kothurud for last 40 years. Active IMA member, Pune branch, awarded Best Family Physician Award by Kothurud Doctors Association, Family Doctor Puraskar by Kothurud Club of Gandhi Bhavan. And I request Dr. Kalpana Bhargava madam to come on the dais to chair the session. She is Assistant Medical Officer of Health, Pune Municipal Corporation and Authority of PCPNDT, Pune Municipal Corporation. So welcome, madam. So I will request a person to start the session.
Hello, good morning all. It's a wonderful session in the morning, what everybody has witnessed. And going to the next session, I welcome all of you in this conference of EVECON, which is Maharashtra State Conference. I request my co-chairperson, Dr. Nandakishore Mantri, to introduce the next speaker, Dr. Manish Machwe.
Thank you, Bharat. Dr. Manish Machwe is a OBGI specialist and gynec endoscopy surgeon from Pune. He is attached to Ruby Hall, Sayadri Hospital, Shashwat Hospital. He has his own hospital in Guru Ganesh Nagar, Kothurud. He has also done, he is also law graduate and always helps our colleagues in any medical problem, medical legal problem, or how to prevent medical legal problem. He is the chairperson, Ethics and Medical Legal Committee, FOGSI. So I welcome Dr. Macho sir. Please go ahead, sir.
Thank you, respected chairpersons, colleagues, teachers, and dear friends. At the outset, let me thank IMA. I see in the office bearers of IMA, all my PUDS members are very happy. Meenakshi madam is there. I'm so sure you are going to have a superb social night tonight. Of course, Aarti ma'am is there, so I hope you had a yoga session today. And if I may say so, what is Pandora's box is something from where anything comes out. And we say abdomen is Pandora's box. To me, Shisagar madam is first in position. That is also Pandora's box. जेव्हा आम्हाला भूक लागायची त्यातलं चॉकलेट निघायचे. जेव्हा पोस्टर लावायला पिना लागायचा त्यातलं पिना निघायचं. So खूप तहान लागली की पाणी निघायचं. So even I work with all of them so closely. But also madam is there, she is with me in NTP committee. I see Balivan madam here and two ophthalmologists and one general physician. So I have to be alert on my toes, speak to the point and not go anything, right? All right, so I pray to Lord Ganesha to save me through this presentation and thank you. After a long time, probably nowadays, I am called to speak on endoscopy also. That's also one of the fields that I do other than medical legal. So again, thanks for calling me here. And this was the earlier philosophy, maybe a few decades ago or maybe a century ago, that the bigger the surgeon, the bigger the incidence. But now, everything is changed, and there are definite advantages of laparoscopic surgery. It's more or less a decade surgery now. Very few patients stay with us for more than 2 days, even if we are doing it for malignancy. And there are so many indications, size will no matter at all. And equipment technology-wise, it's really a boon for all the women. And that would be all I can say. Yesterday we did a laparoscopic radical hysterectomy for a CA endometrium. A lot of doctors come and watch. Please come and watch whenever you want to come and watch. All the slides have my phone number, so you can just take it out. You want to watch surgeries in 3D, 4K, whichever way, just call me and we can definitely arrange that. And that is me. So other than medical legal, thank you again for allowing me. This is something which happened in 1960. I hope you all are reminded by what happened. And this is where Star Wars started, and the tagline was "Where no man had gone before." With all humility, any woman also. It's a women's conference, so man includes women and women includes man. That is a part of law. So in law, you will every time see he means she and she means he. So I'm not talking about only man, but it said no man had gone before, and Star Troopers used to go to those. And then now endoscopy, I can vouch that there are places in the pelvis, there are places in the abdomen where an open surgeon cannot do, and only the endoscopist can do. So there are so many things, so many videos which can be discussed, but for want of time, I can show you some videos and tell you how it is beneficial. So for example, this is a endoscopy view of lateral pelvic wall. I understand that this is IMA, everybody may not be interested, but just to tell you, this is the ureter here. This is the uterine artery, this is the internal iliac artery, and the best way to learn anatomy is by watching laparoscopic videos. And these are places which were very difficult for open surgeon to go, extremely difficult, to access, but with the kind of magnification that we have and with the kind of equipment that we have and with proper training, we can do that. And this is a 2D figure of the same, surgery or the same field which has, shown. So 2D and 3D, that difference is exactly there when you do this kind of surgery. Again, you can see here, this is a case of radical hysterectomy, endometriosis, you name it. Any surgery that we do, I have not opened the patient in last 8 years. So for whatever, even for big fibroids, huge ones for that matter, 3 kg or 3 point, that is the ureter. These are external iliac vessels, this is internal iliac, and this is the uterine which is crossed. So there are so many things which can be learned. Size is no limit at all. Big fibroids can be removed, big uteri can be removed. And obviously with the advent of technology, you can do suturing. So even laparoscopic suturing, I understand that you have to train yourself. I understand that these things have to be mastered. But once you do that, things become very easy, not only for you, but for the patient. And those of you who are, interested in probably playing video games, and it comes very easy. So nowadays kids find this thing very easy because they start by playing video games, etc. So this vision and this hand-eye coordination things becomes very easy. So there are so many pathologies, so many things that can be discussed. Let us see if we can go through some videos, and that should be because otherwise we have huge number of conferences which go on this endoscopy field. So I thought some videos I'll share, and rest of the things we can forget. So this is one video of, it's not only gynecology, so it also helps you in cases of stress urinary incontinence. So this is one video where I don't know. Okay, so stress urinary incontinence, we do laparoscopic works called for suspensions. So wherein you lift the paravaginal tissue, and details may not be discussed here, but even for SUI, the surgeries which were done initially were open surgeries. Now we do laparoscopy. This patient literally goes on the next day. And with the advent of technology, this is very easily possible. So you can see all these videos which I am showing just now, all of them are on YouTube. So you can put Manish Majara 57 of my videos on YouTube. So all learning videos which interested people can watch. And obviously, with the advent of this kind of technology, anything and everything is possible. So if I keep permitted for next 5-6 minutes, I'll show you a few more videos and stuff. Earlier, when there used to be an ectopic pregnancy, we used to think that tube has to be removed. But that is something which has changed now. With the advent of technology, what we do now is we open the tube, we remove the pregnancy, at times we suture it, or at times we keep it open. Because although the incision on the tube looks very big, it's less than 1 centimeter. It's because of magnification that working. So you can open, day before yesterday also I did one salping or something, so the tube can be saved. These are young patients, maybe primary level, who need more of pregnancy, who need to conceive again. So this is one good procedure where we open the tube, remove the pregnancy, and keep it there. This is a pregnant lady with a twisted adnexa. So the point here is, even in pregnancy, laparoscopy is very safe procedure to do. This patient had recurrent pain, and you can see the adnexa is all twisted. I untwisted it, I did a cystectomy, and sort of anchored the ovary, and the things were solved. Otherwise, without laparoscopy, opening up this patient becomes very difficult. Also, this is another patient, where we remove the ovarian cyst and suture. So the chances of adhesion formations are less, and you can save the ovary. So in no situation do we remove the ovary nowadays. Even if there is a very big cyst, laparoscopically you can remove the cyst wall and suture the ovary back. That's not a problem at all. This is another interesting case where it's a bicornular tuberous with a non-communicating horn, and the non-communicating horn had an ectopic presence. So if the horn is not communicating, means there is no cervix to the horn. So from where the sperm went. So we call this as a Superman sperm, because the sperm enters through the cervical canal, goes through the uterus, through the tube, transmigrates through the peritoneum, and then goes and fertilizes with the ovum which is produced on the non-communicating horn. Here you can see this is the normal uterus, this is non-communicating horn, and pregnancy is in the tube which is attached to the non-communicating horn. Again, Superman sperm. This is again very rare case. We published all these cases. This is, if you can see, the previous case and this case are ovarian ectopic pregnancy. Reported as tubal ectopic, but the ectopic pregnancy is in the ovary. That's the uterus there. This is the ovary, and you can see it. This I already showed you another pregnant lady with a huge twisted, ovarian cyst. But as you can see, the cyst wall is all necrosed. So in this case, we had to remove the ovary, because if you have kept the ovary and the patient landed up with infection and pregnancy, septicemia was very easily on the way. Dermoids is very common in young age group, and very easily resected with the help of laparoscope, minimally invasive surgery. And you can open the ovary, remove the cyst, put the cyst in the endobag, and remove the cyst outside. And this way, it is prevention of spillage, which is very important because it can cause chemical peritonitis. As you all know, dermoid cyst will have teeth in it, hair in it, and Shrikanda-like material. So I call it Shrikanda, but it's a very toxic material to the peritoneum. So you can do all these kind of surgeries laparoscopically, and obviously when you put in a suture, there. Now even injuries, this is one case where I was operating and I never shy away from showing my complications, and a lot of my complications are there on YouTube also. So suddenly there was a hole when I was removing a part of adhesion, and what was seen through the hole was Foley's catheter. So this was a bladder which got opened during one of the laparoscopic hysterectomies. No problem. You can obviously suture it laparoscopically. So you can see the Foley's there inside. So you release the part of the bladder from the cave of Regius, take it down to have a tension-free suture. We sutured it in one layer. We finished the laparoscopic hysterectomy and then put another layer suture. She had catheter for 7 days, and the patient was all okay, not a problem. So this is how we can suture even the bladder. Even if there is a bowel complication, sometimes sigmoid gets open when we are doing grade 4 endometriosis. Mind well that all these patients have been
Last 1 minute.
okay. So all these patients are, they have been taken proper consent, they have counseled properly that these complications can happen. So bowel bladder complications can be managed likewise. Obviously, you can see extensive kind of dissections for endometriosis can also be done in endoscopy. This is the case of sigmoid injury which I was talking to you about. So even the sigmoid injury can be sutured. You can see the wall being open there in the background and the sigmoid injury. So we put in, we didn't even put a drain because it was such a clear-cut injury and clear-cut suture. The patient had bowel sound. This is hysteroscopy. So hysteroscopically also so many procedures can be done. Lateral metroplasty can be done. Small fibroids, polyps can be removed. This video of international dilation, etc. I already showed you. I will, sir, just one more minute and just wind up. I will confess that when I started doing endoscopies, everybody starts with a freelancing endoscopy. So I also started doing that. A lot of surgeons used to call me because they wanted me to do appendicectomy. Now it's a very debatable issue whether I as a gynecologist should be doing appendicectomy. But truthfully, so there are appendix. Fortunately, by grace of God, complication is type 7. But this is one of those videos where I did appendicectomy laparoscopy. Everybody was very happy, and I got to pay my PMIs for the night. But I stopped doing that. This is all about fibroids, where big fibers can be removed. I'll skip this very fast. And some innovative techniques. So this is one of the techniques which are innovated, where we tie the uterine artery, remove the fibers, and then remove the ligates and return. So some innovations also we are able to do during our journey. Again, big uteri can be dissected. The last case which I'll just discuss before I wind up is this is one case which presented to us 12 days after cesarean section at Ruby Hall with peritonitis and pus. And it happened because the scar of cesarean section had given away. And we are very happy that we could manage this laparoscopically. I know there was a lot of debate and I discussed in various groups that so many people said we should have opened and not done a laparoscopy because the patient had dilated bowel loops and peritonitis and pus. But I was proper counseling and telling the patient's relative that at any given instant, if you felt like opening, we will open. So you can see here that the scar has given away and we dissected the bladder down. That is the scar there. And laparoscopically, I sutured it, the LSCS scar in 2 layers. This was done on Monday. The patient came out of ICU on Tuesday. She was discharged on Saturday, and yesterday she came for laparoscopic stitching. So her, post-op recovery was very fast and very good, just because we did a laparoscopy. So laparoscopy can even help you manage obstetric complications, is what I'm pointing at here. And obviously, it really pays when you see your patient happy and out of pain. And LRH was the last video, but anyway, so thank you very much. I think I've just put in an insight that a lot of things can be done through the laparoscope. You need proper training, you need a backup. And again, anybody who wants to see live surgery is most welcome. You can take my number, call me generally in groups where I am. I always put my whole week schedule of where I am operating what. Ruby Hall is just next door. Just now, if you all are interested, after I go from here, I am doing a laparoscopic radical hysterectomy for CA endometrium. Anybody wants to see that surgery really live, then come with me. Thank you very much for the session.
Thank you very much, Machwe sir. Thank you very much, Machwe sir, for your excellent presentation. You have made it
Very nice, informative and interesting videos. Hello. Hello.
Hello. May I request Dr. Vajayati Katwardhan madam and Dr. Aarti Nimkar madam to come on the dais to felicitate the Dr. Manish Machwe along with our chairperson and Dr. Meenakshi Deshpande madam, all gynecologist team from IMA. Yes, I am also coming.
इकडे समोर इकडे समोर थँक्यू
Hello, thank you, Dr. Manish, for the wonderful talk. I know your aspect of medical specialty and surgeon's aspect I saw in your endoscopic surgery today. Thank you so much. Now I invite the next speaker, Dr. Vaishali Chetan Deshmukh. Please, madam. Dr. Deshmukh is first female endocrinologist in the city of Pune. She is assistant professor in endocrinology at Sassoon General Hospital and BJ Medical College. She is consultant and head of endocrinology at Dinanath Mangeshwar Hospital, Pune, Deshmukh Clinic and Research Center, Pune, consultant endocrinologist at Ruby Hall Clinic. She is chief medical investigator on award-winning project by Government of India, CSIR, on drug compliance monitoring. She is national and international faculty. She is having numerous publications to her credit and vast teaching experience. She is mentor for pre-marital and preconception hormonal counseling of females under the Asmita movement for girl child. She is mentor for Pune Region for Prevention of Diabetes Women Program run by WDW. She is Director of Wellness of Women, convener of Mind Body Medicine Program, and she is Chief of Pune Thyroid Center at Dinanath Mangeshwar. So we have the wonderful faculty here, nationally and internationally now. So welcome you, madam, for the presentation. Over to you.
Thank you, the chair, for inviting me here. It's always a homecoming when I come to IMA. It feels good to be at home again. Nice to see some old faces, some good friends from college. And also, I'm glad that after COVID, we are meeting face to face. So it gives a special touch when we are talking interpersonally. So I'm here as the secretary of our organization called Sphere. And Sphere focuses on non-communicable diseases, of which obesity forms a big chunk. And in the coming 1 hour, what we are going to do is our team is going to cover most of the clinically relevant aspects of obesity. I have suffered obesity as a child. I have faced the consequences as an adult. And today I stand here as therapeutics of obesity. And I'm glad that I could see this from all angles. And probably I can put it forth to you in the right fashion. So we are now looking at obesity as a disease. And if you see that when we are talking about approach to obesity, it is mainly the BMI approach versus a staging approach. So what we are talking in terms of obesity, we are talking about is it a BMI stage and some practical cases to it. So when we are talking of obesity as a disease, the first step is to diagnose, second is to discuss, third is to treat. So it can't be an approach which is like your patient is sitting in your clinic and you just start a therapy for obesity. So when we're talking about diagnosis, we need to remember that obesity is a Canadian guidelines which tells you that before you start treating obesity, you need to understand that it's a chronic condition. So you're not going to cure it. You're going to control it. So you're not going to be you cannot say that obesity will go when I start you on therapy. Secondly, obesity management is about improving health and well-being and not simply by reducing numbers. So reducing numbers is of course an aim, but it's not the final aim. It's mainly to improve well-being. Thirdly, early intervention means addressing the root causes and removing the roadblocks to the treatment. So it is not that you are going to answer each and every question, but you are going to ease the process of weight loss. Thirdly, important is that success is defined individually different. So it is different for different individuals with obesity. So you can't put everybody in the same scale of obesity treatment. The patient's best weight will never be the ideal weight. This is one concept we need to remember. So what I think of ideal weight is different from what patients think as an ideal weight. So my perception of ideal weight doesn't ever match with patients. So you need to go as closer to the patient's perception when you're treating obesity. So these are the 5 A's of obesity management. First is to assess. Rather, first is to ask. So you can see that if you ask first, most of the obese patients are not willing for therapy. So are they willing for therapy? You don't see so many obese patients in the crowd. You don't treat everybody. You ask the readiness. Second is you assess them, and once you assess them, you identify whether you can advise them. Then you come to an agreeing point, and then you assess that agreement. So this is how the 5 A's work in obesity. So we know the classic definition of BMI. BMI is weight on height per meter square. Now, BMI classification is also well known to us, but what we don't know is what is my ideal weight. So it is usually a simple calculation. You take your height in centimeters. Say your height is 160. So if you are an adult male, then minus 100. So 60 kg is your ideal weight. If you are a female, then minus 105. So 55 is your ideal weight. So if you go home and just calculate for yourself, you know what is your ideal weight. So you don't have to go by what is right, what is wrong. You can just try to reach that weight is the concept. Now, when we're talking about the classification based on BMI, less than 18 is underweight and more than 23 is overweight for the Indian population. So this is what we have learned. We know about diversity, we know about obesity also. Now, what is important to understand is this concept of normal weight obesity. So many of us are normal weight. So normal weight adiposity is a big chunk of population which is not treated. And that is an important population which we need to identify as endocrinologists, as physicians, because these are the ones who will have a lot of metabolic complications. Not the ones who are frankly obese and not the ones who are frankly lean. So this population is what we need to really look into. And then if you see, you have 4 classifications. You have normal weight and obese people. Normal weight can be metabolically healthy or metabolically abnormal. And obese can be metabolically healthy and metabolically abnormal. So what you need to identify is who are metabolically abnormal. So not all obesity and not all normal weight will be metabolically healthy, because our aim is to give well-being as a concept. We are not talking here to improve survival. We are not here to improve numbers. So this is what the concept from patient side as well as doctor's side need to be clear. So there is a mortality paradox actually in obesity. So this is very clearly defined. That when you have different types of obesity, so the metabolically abnormal ones, so these ones, the 8% and 21% have the highest mortality. So metabolic abnormality in any person, irrespective of the BMI, is what gives rise to the problem. So this is what we need to take on today, that you are not going to see obesity as weight. You are going to see obesity as metabolic normal person. So it is metabolically normal adiposity is what we are going to carry on. What is the limitation of BMI? We miss out most of the metabolically abnormal people with BMI. So BMI is one of the concepts in obesity, but what we need to think beyond is the stage of obesity. So how do you identify the stage? So these are the things. You see the medical problem, you see the mental problem, and the functional problem. So if you see this stage 0, stage 1, stage 2, stage 3, and stage 4. You can see that even a person who is normal BMI can be in stage 4. For example, a normal BMI person who has had a heart attack and dyslipidemia can be in stage 4 of functional disorder. So you can be medically and functionally into stage 4. So these are the stages which need to be treated. You need to treat the stage. You don't need to treat the BMI. The grading is different and staging is different. So stage of obesity matters a lot when we are thinking about treatment. Why is it important? Because the NIH data has shown that BMI, if you go by BMI and treat, you are not causing any benefit to survival. Survival is the same. Like all the 4 categories of BMI. What is different is the staging of obesity. So when you have stage 3 obesity, that is metabolically highly abnormal, the mortality is very high. So you are causing more harm if you don't treat the stage of disease rather than the BMI. So this is what we need to take home. Why it is so important for us? Because if you see that yes, EOSS stage, this is the advanced stage, you can see the large chunk of population even in the class 3 obesity, 20% are really in the stage 2 of the EOSS. So a big chunk remains untreated, and this is the person who is likely to die early because of obesity-related complications. So how do you do treatment of obesity then? So you have to think of person-centered intervention. It is not disease-specific. You don't put everybody in the same socket. You identify the risk criteria and see where this person is in obesity, grading and staging, and then decide on treatment. So those with no risk factor, you go into primordial prevention with lifestyle modification. With risk factors, you go for behavioral therapy. With the disease, you think of medical therapy. With complications and with severe complications, you think of medical and surgical management. So this is how the treatment flows. So cases to example. So this is a 24-year-old physically active female, 32 BMI, no risk factor, no functional limitation, mental health issues, reproductive issues are normal. So this is class 2 stage 0 obesity. So focuses on prevention of weight gain through primary interventions, lifestyle changes. You don't think of starting therapy for such kind of patients because you're going to cause more risk of side effects of the drug than treatment benefits. So the health benefits need to be assessed in terms of risk benefit. This is the same kind of female with hypertension, sleep apnea, and depression. Now you have the class 3 obesity, which is stage 2. So this patient needs treatment. Clear benefits of treatment have been proven. You have various drugs called semaglutide, then you have liraglutide, which have now been proven for therapy and they are working. There are a lot of other molecules which are expected to come to India. Then this is the third case of high BMI with osteoarthritis, hypoventilation. Now this is a patient who is stage 4 obesity, very morbid. And then you need to think of aggressive treatment, either a very low calorie diet or a surgical intervention. And these are the patients that you think of bariatric surgery even before you start treating for therapy. Now this is our obesity. Why we have been working in obesity is because every molecule of this decade in obesity has been worked with us. So right from sibutramine, rimonabant, liraglutide, semaglutide, and many more to come. And this is our obesity proforma. If you can see, it's a very comprehensive proforma. You need to do a lot of assessment. You can't treat every patient just starting a drug and telling him to follow a generalized diet and exercise. So every parameter of this is important. It is a 10-page proforma which actually identifies what is the staging of obesity. So if you follow up how we follow this, we follow this Philippines guideline. So we follow that if there is a minimal risk factor, then you think of lifestyle change, moderate risk factor, low calorie diet, high risk factor, start on pharmacotherapy, very high risk, you think for surgery. So this is how we have been working all these years and it has given excellent results. So to summarize, assessment of obesity with BMI alone may be deceptive and USS staging is important, treatment should be person-centric, and that is why we have a lot of panel discussions which are very interesting in terms of how to identify these obesity-related complications. So thank you for the patience.
Thank you, Vaishali ma'am. Thanks for your lucid presentation. Over to Secretary.
For the panel discussion, can I invite?
Just wait, madam, you have to felicitate it.
I would request chairpersons Dr. Mantri sir and Dr. Marathi sir to felicitate Vice President Madam.
I request our Vice President Dr. Rajan Satyaki to join for the felicitation.
Get some more.
May I request the analyst for discussion on stage, Dr. Suhas Kare.
I request Dr. Suhas Kare, sir, to have a discussion. Consultant at in charge Department of Endocrinology, Noble Hospital, Hadassar, Pune. Director Hormone Diabetes, Thyroid and Endocrine Center, Therapy at Pune. His key area of interest are thyroid disorders, young diabetes, parathyroid disorders, gestational diabetes, and pediatric endocrinology. He's interested in traveling and reading.
Welcome, Dr. Kare, for the session, and you will be moderating. The panelists for this session, one of the panelists is Dr. Harshad Parakis. I request Dr. Harshad Parakis to be on the dais. Dr. Harshad Parakis is consultant gynecology oncologist at Parasnas Hospital, Pune. He is past president of QHS. He was president in the year 2021. Head of gynec oncology unit and professor at Bharati Medical College, Pune. Visiting gynecology oncologist at Bija Medical and Sassoon General Hospital, Pune. He was chairperson oncology committee Cochlear 2009 to 2012. His special area of interest are gynecology oncology. So I welcome Dr. Harshad Parakis. So the third panelist,
I request Dr. Chetan Deshmukh sir to be on the dais. He is a DM medical oncologist from Tata Memorial, Mumbai. He is a consultant at Dinanath Mangeshkar Hospital, Jahangir Hospital, Arthritis Breast Health, Sassoon General Hospital, and Medical College. His special area of interest are breast cancer, lung cancer, gynecological cancers, and neck cancer. Welcome all the panelists. I request Gary sir to go ahead with the panel discussion.
Good morning, everyone. Thank you for the kind introduction, and thank you organizers for inviting me here. After the lucid presentation and very comprehensive and yet simple talk by Dr. Deshmukh ma'am, now we are proceeding further. What we learn how the obesity is really a chronic systemic disease, and it's just not the excess calorie intake or less exercise. So that we need to invite in our minds that it is a chronic systemic disease like any other disease, not only in our minds but also in patients' mind, also in the healthcare also needs to understand it is not just the superficial appearance, but it is a metabolic disorder and that needs to be treated. So, if you look at the burden of obesity, which is increasing in the recent past years, we know how the numbers are increasing in the recent past years, maybe due to the lifestyle modifications, due to sedentary lifestyle, so many factors are coming. There are many links to this obesity, right from the metabolic dysfunction, we have links to the diabetes, we have links to the other metabolic dysfunction like non-alcoholic fatty liver disease, to the reproductive system, to the mental health as well. So we, in this session, what we are going to talk that we will address the few areas where how these links are related, how the burden of this obesity is there in the community, and really how it is a metabolic disorder and not the external appearance, and what approach we take. So we have eminent panelists with us. So we will have some question and answer session with them. So may I like to ask a question to Dr. Chetan Deshmukh sir. So he is an eminent oncologist, University of Pune. So what is the relationship between the obesity and cancer, sir? And do you feel that obesity might increase the risk of cancer?
Am I audible?
Hello, yeah. So obesity and cancer, actually this link is being explored pretty recently. Not only about the risk of cancer, but obesity poses several problems even during the management of cancer. I mean, the risk, if you look at the sheer risk, earlier it was thought that obesity only causes hyperinsulinism and then hyperinsulinism related cancers. So endometrial cancers or breast cancer, these were common. Now, gradually, obesity has been also found to be a link for esophageal cancer, colorectal cancers, kidney cancers. So that obesity per se should be taken as a risk factor, especially postmenopausal obesity in women should be taken as an important risk factor, and screening plan should be made accordingly. That is one thing which I would like to mention here. Treatment of cancer always is a problem in obese patients, right? From your dosing, from your surgeries, there are more chances of post-operative problems. Your dosings become tedious, you have excess doses, and you don't know whether to calculate according to the actual body weight, ideal body weight, something in between. So you end up dosing, very haphazardly, and that is never going to be good. So these are important issues of obesity in cancer, which are largely overlooked. People always believe that somebody who is obese is not healthy, that's it. And he's at risk for all other metabolic issues, diabetes, hypertension, heart disease. Nobody thinks of it as a risk factor for cancer.
Yes, sir. I think rightly saying, whenever we utter the word obesity, usually we see it as a metabolic risk factor. We always associate with obesity, hypertension, and maybe respiratory conditions. But again, cancer relatively new, maybe in the research. But yes, almost more than 30 cancers we are now can correlate and with the obesity and they increase the risk of cancer. That was a elaborate answer, sir. So we'll go towards Dr. now Harshad Parasani, sir. So sir is a gynecologist, and I will ask the question related to his area. So how big obesity in the gynecology, sir, and do you feel the obesity is related to the gynecological conditions and which conditions they are? I think.
See, basically, obesity is a silent pandemic. People don't realize that it is affecting the patients to the extent that they actually give some clinical disease or they produce some symptom. We get a variety of patients, especially obesity will be affecting a female right from her menarche to her menopause. If you look at in the menarchal time, she will get precocious menarche, that is, she will be at before 9 years of age. Later on, this same patient can come to us in the adolescent phase with acne, with hirsutism, and PCOS is her presentation. Then when she goes ahead and gets married, at that time she starts having the problem of sexual dysfunction or inability to have a proper sexual relation. Then later on, when she goes ahead, she is unable to conceive. Now, this is a big area of concern because now she comes to you as infertility, and not only is the problem of infertility related to just the infertility per se, but also keeping these patients becomes quite difficult because drugs or medicines that are used for ovulation induction don't act on them to the extent that they would normally act on a normal weight person. So there is again a problem. Then she goes ahead, even if she, after that if she conceives, let's assume, after all the treatment, then comes the question of problems in pregnancy. She will have a problem in pregnancy in the form that she would have early abortions, or later on she would go ahead and have PIH or diabetes, gestational diabetes during her pregnancy. So, and then later on she would land up into maybe an operative in case of say a cesarean section, where again the risk of anesthesia is very high because the anesthetist actually will have to do well with these patients and actually take proper decisions and proper care is to be taken maybe in a tertiary care center because she may require initiatives that may be apart from obstetrics. In case she delivers also, there could be problems of shoulder dystocias and the babies could go in NICUs. So all in all, she again falls into a high risk obstetric category. Later on, if she goes ahead from that, then she goes into menopause. All the problems of menopause are going to be accentuated or exacerbated in these patients, especially we find that they again have a higher chance of having diabetes, hypertension, coronary heart disease, thromboembolism. So as you see, right from menarche till menopause, obesity actually is a cofactor that actually is going to make her into a high risk category for that age group, and then we have to keep on solving these problems for a variety or soft spectrum of diseases that she presents.
Thank you, sir. Thank you very much. This was an elaborate answer. As you rightly say, in gynecological health, or right from the girls when going to the puberty, nowadays we are seeing early puberty due to this excessive fat mass also precocity we are saying, and even in every stage of female's life, right from the unavoidable fertility and the PCOS, and even in the postmenopausal era also. So you are excellently summarized in each stage how the obesity is affected. So as both of our panelists have described cancer and reproductive age group, how this is important, I will just give a brief idea how the metabolic dysfunction with this obesity is related. So as all we know, is now the changing definition of obesity is a chronic systemic disease, and what is previously called as it is just not the mere storage of fat cells. So adipose tissue is not a mere storage of fat cells. Now it is evolved as a living organ, endocrine organ. It secretes a lot of adipokines, it secretes a lot of other inflammatory factors, and it becomes a chronic low-grade inflammation. And that is the basis of developing all this metabolic dysfunction, right from the insulin resistance to the non-alcoholic fatty liver disease, to the cancers, and to the sleep apnea. So all these metabolic dysfunction happens due to this chronic low-grade inflammation, due to the stimulation of pathways, like it stimulates the pathways which are inflammatory pathway, like recruitment of the leukocytes. It also increases the inflammatory other pathways, and it increases the risk of all these complications. Also, if you look at the correlation of the metabolic syndrome, what we call as a metabolic syndrome, which is very common with the obesity, we have different criteria to define a metabolic syndrome, like a patient should be pre-diabetic, that is glycemic control, his lipid profile is deranged, so LDL levels are less and LDL levels are high and HDL is less, then his breast circumference. So all this is related to the metabolic syndrome as well. So I think with that, we will go towards the next question, and may I ask Dr. Chetan Deshmukh, sir, the next question. So if you look at any person who is coming to clinical practice, OPD, apart from his whole illness, like he's coming for some cancer, right? But how he perceived as a obesity as itself a disease, really he perceives or not? How is perception? That we want to know. The house want to know.
Obesity as a disease is still not ingrained into people's mind. People believe that if they are fit and they can do all their day-to-day activities, whatever be their weight, they are okay. Which may be true, may not be true, I don't know. I'm not an expert on obesity, but most people believe that having a little good weight, a BMI of more than the usual, is considered healthy. So most people are not bothered about their weight. They are quite okay with it. The problem stands with us. The problem is at our end, because we don't want them to be overweight. We don't want them to be obese. Now, when I treat my patients, it's a little tricky. I actually tell my patients that during my treatment, you please don't look at weight for two reasons. One, most of the weight loss remedies today are not practiced by standard doctors. Most of the weight loss remedies are practiced on WhatsApp. And WhatsApp University gives a lot of information which is junk. So people follow all those kinds of things and then it messes up their nutrition. Contrary to popular belief, for cancer there is no diet. You can eat whatever you like, you want. My teacher at Tata Memorial Hospital used to tell patients, "Aadmi chhod ke sab kuch khao." So it was that simple. But if you see the diets on WhatsApp, these people end up not eating milk, not drinking milk, not eating sugar, not eating white stuff, and it messes their nutrition. So I tell them, forget about your weight for the time being. Once you finish your treatment, then start looking at your weight. And that actually is more important because once they are through with all their therapies, once they have done with all their steroid doses and ups and downs during chemotherapy, that is the time when they should actually be looking at their weight. And that is the time when they just let go. It is very difficult for me to tell somebody a good diet during my chemotherapy. No, for obesity, to have a good diet for obesity control, you need to have a regular diet. That is something which most people tell that you should have a fixed pattern, regular diet, regular fixed meal, which is impossible during my treatment. When the patient has nausea, he'll have poor diet. When the nausea sets away, he feels like eating everything. So these ups and downs are never good. This problem that he has obesity, and if this obesity is not tackled, he or she has a higher chance of recurrence, is not yet accepted by patient. So after the treatment, when you see them for follow-up for 6 months or 1 year, they have put on huge amount of weight, and they say, okay, now we are done with cancer, so we are through. Now that is something which they need to be trained either by their family physicians or people with whom they interact. Because after my chemotherapy, they don't come to me very often. They come to me once in 3 months or 6 months. So 1 5-minute consult at that time is not going to motivate them for weight loss. But if they are in regular touch with their they can help them reduce weight. And that is a very important thing. And since you are mentioning about metabolic ailments, a lot of our new medicines are causing endocrinopathies. Immunotherapy, which is the latest in our chemotherapy armamentarium, it is known to produce endocrinopathies. Some of the drugs like which act on the mTOR pathway, they themselves are known to produce diabetes. So for a person who is already obese, with these drugs, he or she is going to have worse trouble. So, we want most of these people to keep a follow-up with their regular doctors in parallel. Many of them believe that, well, if I am their doctor, then I am going to treat them for cancer as well as their metabolic ailments, which I am not equipped. So they should have a parallel follow-up. They have to be in your group as well, so that both their ailments are managed. They have to understand that obesity is a problem. Obesity is a separate disease. And if that is not tackled, then other treatment is going to go ahead.
Thank you very much, sir. That was a great learning experience for all of us and great insights how the patient perceives obesity. The same patient, I think, goes to the doctor, sir, as well. How the patient perceives obesity, right? They perceive really obesity, the disease in your practice or not. Like they are coming for some certain other elements.
As I said, they don't actually perceive, and he rightly said that they don't perceive that obesity is the problem. Because if I'm fit, I'm able to work, then I'm fit and I have no weight. But they fail to understand that obesity is the core factor or the underlying pathology, which is actually manifesting itself in various ways, as I just now said before, whether it is in whichever age group the patient comes to us. And so it is I think our job maybe possibly, or it is that we should emphasize on these patients that weight reduction and obesity control through the right person. As you again rightly said, that if you out of all the patients, all the people who are treating obesity, majority are not the ones who should actually be treating them, because we have a variety of answers to this question of obesity. And so, as they should be going to endocrinologists, they should be actually getting the right answers to it, and then possibly whatever problem they come as for a gynecologist, as I said, whether it is in the form of PCOS, or it is in the form of infertility, or it is in the form of later age groups, whether during pregnancy or menopause, or even for that matter because of obesity, diabetes, hypertension, if she lines up with a endometrial carcinoma. So all these lineup of things, for all of them, the basic thing should be that obesity should be under control, the weight should be under control, and that would give us good results.
Rightly said, sir. I think I will summarize. So as both of our speakers, panelists said, so it is not yet in our mind that we don't consider obesity as a chronic systemic disease. Patients, also doctors, and also healthcare. So we don't have obesity as a chronic disease like other diseases, like right from the insurance to the drugs to the medical treatments. So, and most of our patients, they feel that it is just like a physical appearance, that may be the first external appearance, and that may be the bothering them. But I feel it may be at the beginning that if they perceive that physical appearance also it may improve with the treatment, that may be the boost, initial boost. And also we need to imbibe in their minds that it is not just the physical appearance, but the metabolic improvement, metabolic benefits what they will get after treatment. And that will really help in decreasing the risk of other communicable diseases to them. So moving to the next part, I will ask the next question to Dr. Chetradesh sir. Say, so does losing weight help in the reduction in the risk of cancer? Weight loss. Weight loss.
Weight loss definitely helps in more ways than just the risk reduction. If you have a patient who is fit, then these people are less likely to get complications of chemotherapy. People who are borderline diabetics or who have borderline metabolic derangements with obesity, these a little bit of steroids, a little bit of drugs here and there, and they get tossed into the regular pool of diabetes. So that is important. They develop less complications of chemotherapy, less complications during surgery. An obese patient is always a nightmare for a surgeon because even for an anesthetist, for operative peri-operative morbidity. Risk reduction actually in postmenopausal women, obesity is a very important risk factor, which is again largely neglected, or I may say just goes unnoticed. If I ask a lady, she's 55, why have you put on weight? Yeah, I just had my menopause. So it's people feel that it is common to have weight gain after menopause. Actually, it is not so. And menopausal or postmenopausal obesity is actually a bigger risk factor for breast and endometrial cancer. So if they maintain their risk, maintain their weight well within the range, or at least within an acceptable range, that is going to help cancer prevention.
Yes, sir. Please let us know your views as well. Does weight loss really help in your patients?
Yeah, actually, weight loss goes a big way in helping us in managing patients. Like if you have a patient of PCOS, again here, if she reduces her weight by at least 10%, then we'll be surprised that the central fat loss will be nearly much more than 30%. That is one. And second thing is, with that, her menses will get regularized. She will start becoming ovulatory because most of the problems with obesity is hyperandrogenism, and because of the hyperandrogen state, she will not ovulate. She will have anomic cycles. So all this cycle will get corrected. Same in your infertility. If she's coming for infertility, the drugs will start acting. Now, if you have a patient who comes to you is obese, I think it is very reasonable for you with infertility to tell her that you take a break of 3 to 6 months, go back to a proper endocrinologist, to a nutritionist, and get your weight reduced by at least 10 to 20%. If she does that, believe me, the amount of gonadotrophins that we have to give her for ovulation induction reduces drastically. And many times we've seen that with such reduction in weight, they also conceive spontaneously. For all you know, they may not need any infertility treatment. So these benefits are surely there, especially in these PCOS patients or with infertility patients, or even if she is coming with urinary problems. There also again, weight loss is going to actually reduce the symptoms. drastically. So I think it's a welcome move, weight loss possibly more by either by diet or by exercise. Both of them should go hand in hand, and later on possibly if need is should be there, whether pharmacological agents should be added or not, or whether surgical aspect is there or not. This is, I think, in the later stages, if comorbidities are there or not, it should be laid on that.
Thank you very much, sir. So I think as both of us speakers said, weight loss definitely helps in cancers and even the gynecological elements. And as we all know how we practice, our clinical general practitioner, physicians, everyone is practicing, and we all know how the weight loss benefits in each metabolic disorder as well, like right from the diabetes, right from the hypertension, or obstructive sleep apnea. So all these elements, we have trials, we have clinical experience, we have real evidences that how the weight loss helps in each and every point. So, what usually we follow the clinically meaningful weight loss, we usually follow the behavioral model where there is self-monitoring feedback, there is problem solving. So all this stuff really matters in what is called as we call dietary advice. We take the all others take into consideration, but still many of our patients they don't lose weight. It's always difficult to lose weight, and where comes the maybe the next session we will have with the medical management of the therapy. So there are still some areas which are not addressed because obesity.
Sir, 2 minutes more.
Just last 1 minute. So obesity is just a very complex multi-system disease, and it is just not the calorie excess. I will just give a concluding remarks. But there are some areas which are not addressed, like energy expenditure and how body behaves when we lose weight. So it is always difficult to sustain weight what we have lost because our body may go into that state of called as maybe we may need to eat less. So that research is also going on, how the energy body behaves, how the energy expenditure after the weight loss. So that area needs to be addressed. So sustainable weight loss is always to be a goal, and not just the quick weight loss what we see in our day-to-day practice in many maybe camps and whatnot. We see a lot of advertisements. So what I want the very fast weight loss. So what we usually follow, what we need is a sustainable healthy weight loss, and what we should go for the metabolic improvement, not the rather external appearance. And as Dr. Vishal Madam also discussed nicely, how the metabolic obesity is different, how the normal weight person can be metabolically bad, and the overweight person may be metabolically normal as well. So that all these things scientifically we need to follow under the medical supervision, and that's how we can definitely reduce the burden of obesity. With that, I think we will conclude the session. After that, we have the medical management. We are not going to discuss here medical management. We have Dr. Nikita Doshi from Kolhapur. She is a young eminent endocrinologist. She will be taking the medical management of obesity after this session. Thank you very much for inviting all of us here. Everyone, we thank you all of them. Thank you very much.
Thank you, sir. Now I will request our Past President Dr. Mohan Joshi sir and Vice President Dr. Rajan Sancheti sir to come on the dais to felicitate our moderators, and with that we conclude this very extremely useful session where it's a pandemic, obesity is a pandemic, new terminologies have been added to knowledge of all the listeners. Chairperson to join the felicitations.
सेंटर में आप सर जॉइन हो सर हाँ सर थोड़ा हाँ
Request.
स्लाइड पे Get some more. Good. Photo side ले जाओ. Like do this. Okay, okay.
Okay.
Thank you.
हे ट्रिगरच बंद झालं आणि ते काय म्हणायचं, ऐक ना शुभम, नॅचरल मार्क आधी आणि नंतर त्याच्यानंतर सगळ्यांना उभं करून एकच मार्क, म्हणजे एक मार्क म्हणजे त्याचे 2-3 घे.
Good afternoon, everyone. And with this, we conclude this session of obesity and related issues. Our next session is on drugs for the treatment of obesity. I invite Dr. Nikita Doshi. She has done BM in endocrinology from Mumbai, and I think most of the time I've been to some gyms where they say जब बहेगा पसीना तब देखोगी हसीना. लेकिन Dr. Doshi is going to tell us something different than pasina. Let us hear. Thank you. Welcome, ma'am.
Hello everyone, it's an absolute pleasure and honor to be with you all this afternoon. And what can be more rewarding to share the phone with my mentor, Dr. Vishal. I have been a student in UG and PG, and she is the one my role model in endocrinology. Thank you. So in the next half an hour or so, what I would be discussing is regarding the drug treatment of obesity. So we'll start with a very routine case which we all, you and me, come across in our OPD. So this is a 32-year-old woman. Really struggling with the weight. Now comes with a newly diagnosed type 2 diabetes. 32-year-old complaining of knee pain, some snoring, some acid reflux. If you go talk about her history, she has been having oligomenorrhea since her puberty. She needed IVF for her conception, and now she presented with some polyuria, and you do her A1C, it's 9.5, sugars are 200. This is another complication she ended up with. You check her blood pressure, it's 144/86, and her dyslipidemia, LDL is 167. Sonography shows her fatty liver. So now she is into that entire metabolic sequelae of obesity which Madam spoke about. And if you look at her BMI, it's 38.2. It is not just the BMI; it's the BMI along with the metabolic plethora that she has come to you. She has been struggling with her weight. She's tried diet multiple times. She has been trying Herbalife, some meal replacement sachet, getting down 5-10 kg. And believe me, in no time she gains that weight again. She has been advised multiple times on her diet, exercise, by the gynecologist, by the treating physician, and always is projected that it's her fault and she should just be more aggressive with her diet and lifestyle. So we would address her diabetes, we would address her blood pressure, we would address her dyslipidemia, but are we missing on something? Are we missing on something since a very long which needs to be addressed? As a medical person, should we address her obesity as a chronic disease like we are addressing her diabetes for her survival? So why do we need to address her obesity? The moment we get her weight down in a very therapeutic manner, even a 5% weight loss is going to give her a very good glycemic control with lesser medications and a good blood pressure control with very less medication. A 5 to 10% weight loss will even prevent type 2 diabetes, is going to improve your MASH, is going to significantly improve your PCOS symptoms, significantly improve your dyslipidemia. The moment the weight loss is 10 to 15%, the incontinence gets better, the reflux gets better, the knee pain gets better, even replacement surgery could be avoided. And if the weight loss is more than 15%, you even can have a type 2 remission, a diabetes remission in this particular lady. So of course we should look at the underlying problem and not just address the current issue. And with regards to diabetes, the studies show that if you have a 15-20% weight loss, 80% will have remission of type 2 diabetes, provided that the patient is obese, you do it in the early start of diabetes. So should this be the only our end advice? Please eat a little less and walk a little more. Will this advice suffice, or should we go one step ahead and talk about medical management of obesity with this particular lady? So no more obesity is just calorie intake and calorie burning. It is not just that equation. There are multiple factors. Our current understanding of obesity is far beyond that. Now we understand that the appetite of a person itself is regulated by more than 10 factors, more than 10 organs. So patient would have that craving, patient would have sustained eating, patient would have emotional eating, and however hard you tell the patient to eat less. Somewhere it's a complex biology that is pushing the patient to eat those amount of calories, and the metabolism that is very resistant, which we need to address. So if you look at the, I will not go into the details of this busy slide, but appetite itself is regulated by multiple factors, and just asking the patient to eat less would be sustainable only for 2 months unless we address this therapeutically. So this is the real story. Only 5 to 10% are going to actually achieve and maintain that weight loss a year or more, and this needs to be changed. If we look at the diet and the popular dietary regimens, after a year, if you see the adherence is pretty low and the lost weight is usually regained. The body is more smarter than we are. It is going to change its metabolism. It has always been thought to regulate the energy. It is going to make your cravings more, your hunger more, your emotional eating more. It is going to put your resistance low and try to gain that all lost weight. So we are itself fighting against that body's super smart metabolism that is trying to regain all the weight that it has lost. And this is how our body, our biology has been adapted to gain back the weight which is lost for energy conservation. And we have to fight this, and this fight is really not very easy. All of those who have tried getting down weight, we know the real struggle. So, of course, lifestyle management, diet and exercise is the cornerstone of therapy, but is often inadequate and often not sustainable. And the other end of the story is bariatric surgery, which is going to give a very significant result, but that is usually acceptable after a BMI of 40 in most of the settings. So what do we do in the gap between, where the loss needed is almost 5 to 15, 20%, where most of our patients would sit in? The lifestyle is insufficient. Bariatric surgery is a little not welcoming option, a little far option for that particular BMI. Here is where the medical therapy, the treatment gap that we all see in our OPD, here is where the medical therapy actually works. So we today talk about the pharmacotherapy in the clinical obesity management. So why do we need these drugs to treat the obesity? First thing, it is a disease, it's a chronic disease. It is the underlying reason for multiple other diseases. Unless addressed, the amount of medication that we will need to control its sequelae is going to be more. Rather we control the weight. Even in diabetes now we do not have a glucocentric approach. We do not want the BSI to be 110, 120. We want a total weight-centric approach. We want the weight to be down. It's an entire holistic approach because we know the mortality reduces when everything is addressed and not just the glucose. So obesity is a progressive disease. It's a global pandemic which is actually decreasing the life expectancy. Diabetes is a very severe epidemic that we all are facing, and the complications are actually improved once you have a good weight loss. Weight loss with a diet and a physical activity is limited and usually difficult to maintain, and maintenance of weight loss is challenging because of your metabolic adaptation. So pharmacotherapies have a major role to play. Now, if you look at what guidelines have to say, where do you use drugs to treat obesity? It says whenever the BMI goes for Asian population, because we all are thin fat, though we look thin, we have a lot of adiposity, we have a lot of central obesity, and therefore the BMI goes more than 25 itself, it says use pharmacotherapy. And when the BMI goes more than 27, even without any complication, you should talk about pharmacotherapy, you should discuss about this, you should open up with the patient and refer him for an appropriate medical management of obesity. Now, when you combine pharmacotherapy along with diet exercise, we are not saying that diet exercise should not be, of course, that is the cornerstone, but when you add pharmacotherapy to it, the weight loss is more robust and more importantly, it is more sustainable. Now, what are options do we have? Previously, we had limited options. We had in India only Orlistat, but with the upcoming GLP-1 analogs, the results are pretty impressive and the medications are pretty safe, giving us excellent results. So today I will be discussing only regarding the GLP-1 analog, the liver molecules, the top of the town, which is giving us very good weight loss result. Orlistat, of course, works, but only when the fat in the diet is excess, it is going to give you a modest 5% weight loss. That is what it can do. We talk about the GLP-1 analog, the liver molecules, and how do they work. So if you look at liraglutide is available in India as an injection form, 1.8 mg to 3 mg is approved. Those for obesity not available in India, but 1.8 yes we are using. We are going up to 3 mg, and the weight loss dose is 3 mg. It's a subcutaneous daily injection, and the weight loss seen with this particular study is 6%. Going to a more powerful GLP-1 analog, semaglutide. Semaglutide, how does this molecule work? It is going to reduce your appetite, it is going to reduce your craving, it is going to reduce your emotional eating, it is going to delay your gastric emptying, finally resulting into a very good weight loss which is sustained until you are on the medication. So if you look at the STEP study across 4 spectrum, if you can see the weight loss result as compared to placebo, it is almost to the 16-17% from the baseline. So if you start somebody on in 80 kg, almost you would get down to 60-65 with this particular molecule. It's a subcutaneous injection which is given weekly once. We uptitrated it from 0.25 to 0.5 to 2.4 mg shot once weekly subcutaneous injection, which is to be given, and we uptitrated gradually going up to 2.4 mg. That is where we see the weight loss, robust weight loss to the tune of almost 17% of your body weight. And if you see how many people lose weight on this weekly one subcutaneous shot, you can see almost more than 5% weight, 85% of the patients would lose, and even 30% would lose more than 20% weight loss, which is really impressive. And if we look, it is not just the weight loss that this newer molecules give us. GLP-1 also give you a very good body composition. If you look at the waist circumference, there is almost 13 centimeter waist circumference reduction. I think for most of the women this is very impressive, and this is what we all struggle to get the waist circumference down. If you look at the body composition by DEXA scan, the fat mass, even if few patients lose only 5 kg weight, but what we see with this molecules is that the body composition differs. The fat gets down, the lean mass goes up, and the patient becomes more metabolically healthy. And that is what Madam spoke about. After all, it is the survival and not the numbers. So this molecule, even if they are giving you in few patients, say a 3-5 kg loss, it is going to give you a very good body composition, which is metabolically very healthy. So this would help you to manage a lot of metabolic complications. If you look at the visceral fat, this is what is important. Say we have 2 females with the same BMI of 38. One lady has all the metabolic plethora, another lady does not have no diabetes, no blood pressure, no dyslipidemia. She says, I am a pretty heavy, obese lady. So what differs between the two is the visceral fat. When we do a DEXA scan for both these ladies and we look at the visceral fat, the one with the entire metabolic plethora actually has double the visceral fat as compared to the one without metabolic plethora. So these agents would get your visceral fat down, and this is what is going to get your metabolic composition under control and increase your survival. It is overall going to improve your cardiovascular and metabolic risk factors and not just the weight. So of course, it will get down your weight, it will get down your waist circumference, it will get down your visceral fat, it is going to even control your A1C very robustly, and is going to control your cardiovascular risk factors. So overall increasing survival. And what about the acceptability? Previously, we did have some problems with weight loss medications, the safety, but this particular class we have been using for type 2 diabetes, and then when weight loss was seen, they were used for obesity. The safety profile is pretty safe. There would be some GI adverse effects, some nausea in the initial part, but after a while there is a lot of tachyphylaxis and the patients are not willing to stop the medications. They are really safe. The risk of pancreatitis, MTC is just in the animal models, very few robust data of association. So pretty safe molecule. GI and nausea is a problem, but most of the patients would have tachyphylaxis later on. So 2.5, 2.4 mg weekly semaglutide has shown us very robust results. Now there are a lot of molecules which are in the research giving us more robust weight loss. They are expected to come. We look at cagrilintide, which is a combination of cagrilintide and semaglutide. So this is going to give you weight loss beyond semaglutide, which we just spoke about, without increasing any kind of adverse effects, increasing with the same tolerability. And if you look at the weight loss, it is almost 17% as an average, which is really impressive. Another molecule, tirzepatide. Now we use this. Semaglutide is a GLP-1 analog. Tirzepatide is a GLP-1 along with a GIP agonist. Together, they become more powerful. Initially, we were reluctant to use GIP agonist, thinking it is obesity. But when we use together, it actually amplifies the weight loss which is seen with GLP-1 analog. So this amount trial, if you look at the results, the amount of weight loss was almost to the tune of 20% of your baseline weight. So 20% of your baseline weight getting down there safely over 56 weeks is what was shown. These are number of molecules that are lined up, which will be expecting in coming years. And if everything goes well, the way now really we require vagotomy for peptic ulcer with the good use of proton pump inhibitors, could be in the near future. Bariatric surgery also would be really required if this molecule come with that robust result. So this is awaited. And of course, surgery, this is a pillar. We have to work in synchrony with the pediatric surgeons. And once the BMI is more than 40 or the patient is super obese, but the BMI is more than 50, it's a very good option. But what happens with the bariatric surgery also is that there's a rebound weight gain. We all know a couple of people who had a bariatric surgery done after 10 years, 20 years down the line. They gained all the weight that was lost. So the stomach, which was made smaller, sometimes expands. Sometimes the ghrelin axis increases, the appetite increases, the patient's craving increases, everything gone together. Over the 10-20 years, the weight gain starts even after a bariatric surgery. So there, where again we have a role of pharmacotherapy. Most of the bariatric surgeons are now using liraglutide post bariatric surgery once the appetite starts increasing, so that the weight loss is maintained. So to summarize my talk, obesity is possibly the biggest epidemic affecting humans, and it is not patients' fault, not their fault approach, and just eat less, walk more should not be sufficient. We have to go one step ahead. There's lots of social media which is claiming and which is diverting patients. We as doctors should guide them to a proper therapeutically studied management which is needed. Lifestyle management, of course, is a cornerstone, but often not enough and not sustainable. Pharmacotherapy that combines weight loss, long-term safety, weight loss maintenance, and reduced complications is much needed, and patients should be promoted. Appropriate patients should be promoted for this particular therapy. GLP-1 receptor analog have shown a very robust clinical evidence as an anti-obesity medication. Thank you.
Can this semaglutide be used as a treatment for obesity in non-diabetic?
Any obvious question for obesity?
Madam, I was listening to your talk with easier. Dr. Kedar Patil, I'm a pediatric surgeon. I was listening to your talk with great interest. So I would just clarify 2 points. One is pediatric surgery is indicated in BMI about 32.5 with comorbidity. These are Indian OSCE guidelines, the Pediatric Surgery Society of India. 32.5, it's not 40 with comorbidities, and it's 37.5 without comorbidities. And secondly, you mentioned about weight gain after bariatric surgery. 1 or 2 people don't qualify or cannot reflect the entire population. It's 15 to 18% in sweet eaters. So we have to be cautious when we are operating sweet eaters. We generally don't tend to go for a sleeve gastrectomy. We go for a bypass. So it's a misnomer or myth that all patients will gain weight. And that is the exact reason why this surgery has come under insurance. Most of the insurance companies are now covering bariatric surgery because they know the long-term benefits. I think I've made my point. Thanks.
Yes, I think the reason why we are having this symposium here today on obesity is because we fail to understand that obesity, the disease lies in the brain. It's not in the stomach. So when we are talking about therapeutics, the targets of therapy, one part of the target is the stomach. But the major part of the target, 90% of the obesity lies in the brain. So unless we target the neuroendocrinology, the control of obesity is difficult, whether it is with bariatric or therapeutics or with lifestyle medication. So I think the reason why we are focusing on this is because Fear is working in a long way in behavioral endocrinology, and that is why I think all the team that was here today is here to focus that we think beyond what we commonly see as BMI. So we just don't go by guidelines, we just don't go by therapeutics, we go by changing the mindset of our obese patient, and that change has to be lifetime, and it's not only for the duration of surgery. So this is what we need to take over.
Thank you very much. Thank you, Madam.
Pediatric obesity.
Dr. Nikita Joshi, it was a very impressive and very nice presentation by you.
And with this, we conclude this session. And thank you very much, sir, for contributing some bariatric issues also in this. This completes the full picture of obesity treatment, medical as well as surgical advantages and disadvantages. Thank you very much to all my co-chairmen.
Now I request Executive Trustee IMA Dr. Sanjay Patil and Joint Secretary IMA Dr. Kedar Patil to felicitate Dr. Nikita Doshi Madam.
सेंटरला या नाही थोडंसं इकडे ओके इकडे समोर थँक्यू
And wait a minute. We have to felicitate all the chairpersons. So chairpersons, please accept our token of appreciation. Yes. Dr. Prakash Marathe. Dr. Sanjay Patil to felicitate Dr. Nandakishore Mantri. Dr. Madhuri Rao. And Dr. Kalpana Parivalta Madam.
थांबत असेल जवळ सारखा सर इकडे समोर इकडे समोर
Hello. Please join the photo. Dr. Vaishali Deshmukh Madam, Dr. Khaire sir.
Thank you.
Dr. Doshi. Dr. My friend, Dr. Harshad Parasnis.
मॅडमला राईटला घेते सर मॅडम जरा इकडे समोर ओके थँक्यू
We now go to the next session by Lokmanya Hospital. To chair the session, I invite President-elect IMA Maharashtra State Dr. Ravindra Kutte on the dais. Dr. Ravindra Kutte is consulting surgeon Srirampur. He is onco and GI surgeon. He has done MS with gold medal, LLB first Pune University, LLM. He is member and fellow of 20 national and international organizations. I invite Dr. Ravindra Kutte on the dais. Also, we have Dr. Asha Zadav. I request Dr. Asha Zadav madam to please come on the dais. She is first lady surgeon of Kolhapur, practicing in private sector for last 35 years. She was president Indian Medical Association Kolhapur branch 21-22, chairperson WDW IMA Maharashtra State year 2021, successfully organized EVECON 2021, past president Kolhapur Surgical Society, past president Deccan Surgical Society. I also invite Dr. Rajan Sancheti on the dais. He is vice president IMA Pune. I hand over the session to chairperson. There is a simple announcement by IMA. I request there is a announcement by IMA Mumbai West.
Good afternoon to everyone. The IMA Mumbai West branch is hosting the state CGP conference. It will be held on 17th and 18th September on Saturday and Sunday. It is 2 days of scientific feast, and you will get 3 credit points. The registration charges for physical conference is 300 for IMA members and 500 for non-members. And it is also virtual conference is also there, and the charges are 400 for the virtual conference. And there are a lot of lucky draws and delegate gifts for only physical attendees. So please take advantage. You can we will be playing the invitation video, so you can call the IMA Mumbai West office to make your registration. Thank you.
See, just along this for delegates, the whoever is not registered or they have accompanied with a non-registered person, so you can have a lunch coupon at the reception counter for 500 rupees, and for banquet it is 1,500 rupees. Thank you.
Chairperson. Good afternoon, everyone. At the outset, let's congratulate Dr. Meenakshi Deshpande Madam, Dr. Vaijayanti Patwardhan Madam, and the whole organizing team of EVECON 2022. For this session, I would like to invite Dr. Shardul Soman, who is MS in Orthopedics and Fellow in Spine Surgery from New Delhi, New York, and Singapore. Presently, he is attached Okay, there's little change. I would like to invite Dr. Anup Gadekar, who is MS in Ortho, and is having fellowship in arthroplasty, Australia. Presently, he is having attachment. He is a consultant arthroplasty surgeon at Lokmanya Hospital, Pune, and his special interest is robotic joint replacement surgery. His hobbies are music and swimming. Now I invite Dr. Anup to give his presentation.
Yeah. Good afternoon, everyone. Thank you, organizing team, for having me here. My talk is on the robotic technology in the joint replacement surgery. Before we go into the details of the robotic joint replacement surgery, let's have a short discussion on the arthritis and its burden on our society. Now, there was a survey conducted in 2013 about the disabilities, different diseases causing the disabilities in the world. And as per the survey, the commonest cause of the disability in the world was the arthritis, accounting for almost 17.5%. And as we grow older, you can see the prevalence of the patients with arthritis in the society keeps on increasing, reaching up to 60% in patients who are older than 65 years of age. As we all know, the arthritis can be broadly classified into three categories, like osteoarthritis, inflammatory arthritis, and septic arthritis, out of which osteoarthritis is the most common cause. Now, if you look at the stages of arthritis, we can have 4 stages, of which stage 3 and stage 4 patients requires total knee arthroplasty. Total knee arthroplasty, as we all know, is one of the most successful surgery. But what makes it successful? So there are many advancements being done in the implant material, what we call it as a tribology. Then there is an improvement in the implant design and surgical techniques, and lastly the technology. Previously, we used to have cobalt chromium implants routinely used for total knee arthroplasty, but with recent advancement, we have now the titanium niobium nitride, what we call it as a gold knee, which is 8 times harder than the cobalt chromium material and has a good wear properties. Then we have something the ceramic, what we call it oxidized zirconium, which is called oxenium, which is again having a good wear properties. Then something in the polyethylene, we have vitamin E coated polyethylene. So the vitamin E acts as an antioxidant and prevents free radical induced wear in the joint. Now, if we have to look into the implant design, there are different designs available, like cruciate retaining, in which we don't cut the posterior cruciate ligament, we preserve the ligament. And then there is a cruciate substituting means design, in which we have to sacrifice the posterior cruciate ligament. Then we have something in high-flex design called as PS150, CR150, claiming to get more than 140 degree of knee flexion. And recently we have some anatomical designs as per the natural anatomy of the knee joint, which are journey to and person. In surgical techniques, traditionally we use a medial parapatellar approach, but now with advancement we have some quadriceps pairing approaches like subvascus and midvascus approaches that helps in getting early straight leg raise and good extensor mechanism. Now, there are other approaches, what we call it as a minimally invasive approaches, in which we don't even the patella, we just subluxate it so that the patient is having minimal pain and early recovery. Now, talking about technology, it started with navigation, what we call it as a computer-assisted surgery. Then came the handheld navigation, the smaller version of the computer navigation, what we call it as an opto-align. Then there are patient-specific blocks available, which were designed as per the patient's natural anatomy. And the latest addition to this is the robotic assisted surgery. If you look at the computer-assisted navigation or the computer-assisted surgery, this is the first advancement in the joint replacement. It uses the real-time data of the patient, and it is image-based. We don't need X-ray or CT scan to be feed to the system, and this system only helps in operative planning, but it doesn't help in execution of the plan. This is the opto-align. It's like a small mobile which we use, and it has the same properties as a navigation. The advantage being handy and cheap. Then there is the first generation robotics in the form of MECO. It is an image-based robotics. We need a CT scan of the patient pre-operatively. We feed all the images of the CT scan into the system, and after feeding the information, the system helps us in planning the surgery. And in addition to that, it helps in the execution of the plan.
But if you look at the overall structure of the robotic, it is less surgeon friendly and acquires a lot of space in your operation theater. Then we have something called as second generation robotics, and these are bit smaller units. It consists of a camera, console, monitor, robotic arm and foot system. These are image free and based on the real-time data. Then there are third generation robotics, which are modification of the second generation, in which we have the console size reduced, software advancements are there, and instead of a big fatty screen, we have a tablet screens available, which we can move in OR. These are some of the robotic systems available with our hospitals. Now, question, we must have a question that why do we need these robotics when we are doing it so well with the conventional instruments or also so many years? After doing a successful surgery, there are multiple papers being published saying that 19 to 25% of the patients are not satisfied after their knee arthroplasty. There are various reasons for that. Some patients feel that the recovery is lengthy. Some patients have activity limitations. In some patients, their expectations from the surgery never met. In 6 to 70% of patients, they have residual anterior knee pain, and some patients complain that their knee don't feel normal. There is one good paper published in Journal of Arthroplasty in 2018 by Brian Parsley, stating the drawbacks of the conventional surgery with the manual instrument. He stated that there is inconsistency in the implant placement, inconsistency in bone removal, human errors are there, less predictable outcomes, and lack of reproducible accuracy. And we require many instrument trays for conventional total knee arthroplasty. Now let's quickly see some of the screenshots of the robotic surgery. After we register different landmark points of patient's knee, we take the knee to the range of motion. We calculate the natural range of motion, preoperative range of motion of the patient's knee. Then we take the stretched range of motion. What we call it as a stretch, that we apply valgus and valgus stretch to the knee, and we see how much ligaments are lax and tight in flexion and extension. After that, using the robotic probe, we form a 3D image of the patient's femur and tibia. Once we get the 3D image of the femur and tibia, based on this 3D image, the robotic system gives us the tentative implant size and the tentative position of the implant. You can adjust this position and size as per your convenience, how you want your final alignment, how tight you want your knee, how lax you want your knee. So this can be changed by the surgeon. Once the final plan is ready for the surgery, then the system gives us a color-coded area, that is the mapped area, which we are supposed to remove with the help of robotic arm using a high-speed burr. The burr doesn't act outside the coded area. This is a small video where you can see I am using the probe on the patient's femur surface, and on the screen you can see a 3D image of the patient's knee is being prepared. Similarly, after finishing the femoral registration, we do the tibial registration, and this is how we get a 3D image of the patient's knee joint. This is how we get the color coding depending upon the size you have chosen and amount of resection is decided. The color codes are different. Whatever is seen in the violet is more than 3 millimeter in thickness. Once you remove the violet patch, then there is a blue color which indicates the 2 millimeter thickness is remaining. After you take out the blue color, there is a green color which indicates only 1 millimeter of the bone is remaining. And once you reach the white surface, that is what the desired level of resection we want. And here you can see, as we finish with the burring, some part of the mapped area gets white. So that is what we want to achieve with our burr. Now the advantage of using burr is it works only in a precise mapped area. If we take deliberately burr outside the mapped area, it stops rotating or it withdraws. So even it is soft tissue friendly, there are less chances of injuring any other soft tissue structure. I would like to show some of the videos of the patients who are benefited with this surgery. This is a farmer from a remote village in Ahmednagar, and you can see how miserable life he is having. So he came to me with this kind of deformity, and after the robotic surgery, you can see this is the post-op second video. Patient is able to walk with the help of walker, and he is having a straight legs. And we continue patients. We keep patient hospitalized for 4 days. In those 4 days, patient is able to use washroom on his own. This is a video at 6 months' time when patient traveled with bus and visited me for the follow-up. This is another patient, farmer by occupation, 72 years. He was operated for both knee replacement, and this video was sent by the patient showing me what he can do after the knee replacement surgery. He climbed the hill to attend the village festival in his hometown. Another lady, just we discussed about the obesity and different health illnesses associated with obesity. Knee arthritis is one of them. So as you can see, this another lady in her 40s, mid-40s, suffering from rheumatoid arthritis, having her left knee completely damaged with the arthritis, and this is her post-op second video. You can see the patient is able to walk properly. These are some of the patients who are benefited with the robotic surgeries. Now, do we have some literature supporting the advantages claimed with the robotic surgery? So there are plenty of publications available. The Journal of Arthroplasty is one of the reputed journals in the field of arthroplasty. This is a paper published in Arthroplasty Journal stating that with use of robotic assisted unicompartment in the arthroplasty, we can have improved alignment and less outliers. Another paper states that robotic assisted surgery has become increasingly popular in unicompartmental knee arthroplasty as it allows surgeon to more accurately and reproducibly plan and achieve operative targets. This paper states that the robot-assisted technique showed better accuracy in femoral rotational alignment compared to the conventional surgery. One more paper states that the implant accuracy and gait analysis showed significant advantages in robotic arm-assisted group. Pain scores for the robotic arm-assisted group were 55.4% lower. Another papers showing the improved early functional recovery, decreased pain, reduced time to hospital discharge compared to conventional G20 care. Advantages of robotic assisted teaching include better component accuracy and precision, soft tissue protection, increased patient satisfaction. Another patient saying there is the improved accuracy and precision of component implantation and mechanical axis alignment and joint line restoration. One more patient paper saying that we can optimize the precision of bone preparation and component alignment, and we can reduce the outliers using robotic technology. So to summarize, the advantages of robotic surgery, we can say that it improves the accuracy of the surgery by giving proper implant positioning and limb alignment, and we have a reduced outliers. It is safe, as I said, the burr which we use is safe. Then there is a decreased hospital stay, decreased blood loss, reduced post-operative rehabilitation period. It eliminates movement errors and it has a quick productivity. Thank you for your patience.
Thank you, Dr. Anand Gadekar, for excellent lecture. I would like to ask whether there is learning curve
Yes, ma'am. Recently, we published our paper in Journal of Robotic Surgery, in which we studied the learning curve for robotic technology, and we found out that the learning curve is almost around 25 to 30 cases. Means you can achieve the operation time as per your conventional surgery in 30 surgeries.
And second, cost.
Yeah, definitely, with added technology, you will have to bear some added cost to the surgery. But if you see the benefits of the technology, the cost is not big.
Thank you, sir.
I request Dr. Raju Aryani, sir, President-elect IMA Pune, to felicitate Dr. Anup Gadekar.
Thank you.
Good afternoon. I'd like to introduce the second speaker, one of the stalwarts, Dr. Shardul Soman, spatial area of interest, minimum invasive spine surgery, deformity correction, endoscopic spine surgery, one of the best spine surgery in Pune. Sir is a nurse ortho fellowship in spine surgery in Delhi, New York, and Singapore. He's a multifaceted personality and very well known in orthopedic world. Sir has, I would say, different hobbies too. Football, and I'm seeing in very taking missions too. So also, I would say a rare gymnastic hobby. So he's a gymnast too, very smart personality. So I request sir to take over for this session. So please.
Good afternoon, sir. Very thank you for giving me this opportunity to IMA Pune and for the IMA Maharashtra. Let's begin the talk. So my talk is predominantly on advances in spine surgery. So just before that, I am going to highlight few points why spine surgery has still not been that common in practice, or it has not been that commonly accepted treatment modality for spine ailments as some other orthopedic managements like say arthroscopy or even joint replacement. Some of the challenges predominantly include complex anatomy. So when you see spine, every two vertebrae you will have three joints, which includes the disc and the posterior two facet joints. And this includes for only two vertebrae. You can imagine 33 vertebrae having similar anatomy. Lot of differentials. Most of the patients will come with mixed picture, which obviously includes obesity, predominantly diabetes, hypertension, associated diabetic neuropathy, and other comorbidities as well, which give you a mixed picture many a times for the presentation. And because of this, lot of the patients don't get the expected outcome because they are having expectations which are not realistic. Next, obviously, there is no standardized protocol. You can take a case to 10 surgeons in Pune itself, and you might have 5 surgeons suggesting you some surgical, which is different approach, 5 surgeons suggesting you a different approach. So there is a lot of
more than this communication, because spine is such a complex anatomy, there is a lot of pros and cons of every approach that is being handled. Obviously, fear of undergoing surgery because of all these previous causes are highlighted. Lack of availability of expert is slowly reducing with the increased amount of doctors being passing. So just to highlight what are the causes: obesity, arthritis. I don't per se see arthritis as a cause. I think arthritis, spondylosis is a nature's rule more than a aberration. It is a physiology that has to happen. The only thing is whether it affects your body and how much pain it causes. That is different from person to person. Other causes, obviously, age, which you cannot limit, and poor working posture. I think I cannot see anybody sitting in a proper ergonomic posture even right now. So I can't see patients sitting in, we can't sit in an ergonomic posture. Obviously, there is something called as text neck syndrome. This is a terminology which is in WHO literature now, because from the kids being born at 6 months till the age of their death, there is everybody and each and everyone wants to use smartphones. Just to highlight, I think what we can do, we cannot restrict smartphone. That is not something that is going to happen. We can see ourselves in that 15-degree category if we can. I think that is more possible for us as well, and advising to the patients. So this obviously has increased the amount of arthritis or cervical or neck pain that the patients present in the younger age group, between 20 to 40 years age group, which generally should not be the case. So what are the common spinal disorders? Predominantly disc herniations, lumbar canal stenosis. Cervical myelopathy is a chronic disease which takes time to present. Listhesis, vertebral fractures could be traumatic, and the other cause we'll discuss, osteoporotic fractures. Infections and tumors, and obviously deformity, it again could be age related in the adolescent age group, which are idiopathic scoliosis, or in the elderly, which are degenerative. Now, just to highlight, most of these cases, be it herniation, lumbar canal stenosis, they can be managed conservatively to a large extent. What are the symptoms? Back pain, neck pain, radiculopathy, numbness, instability of gait, muscle weakness. One important highlight is tandem stenosis, where patients have stenosis at cervical and lumbar both. So there is a mixed picture presentation, and many times it is missed. So we need to always get a whole spine screening MRI. When we advise MRI to even our relative, better get a whole spine screening. So this is the general treatment modality that is there. You can see the surgical requirement is very small. Obviously, this entails if all other treatment, that is a healthy lifestyle and physiotherapy and exercise all are followed. Now, what are the goals of advancement? Predominantly preventing the muscle surgery. All of us who practice say laparoscopy or endoscopic procedures will be having an idea of how much reduced muscle damage and laparoscopic surgery causes as compared to an open, say, laparotomy as well. So, similar is the case with endoscopic spine as well. Safe spine surgery to prevent a lot of complications, especially dreaded complications of muscle weakness, post-operative paraplegia, gallbladder incontinence in complex cases. Early recovery and rehabilitation, because everybody nowadays, even we can't take leave for more than 2 days, so patient has to be up and about in 2 or 3 days. And lastly, spine care in the elderly, because our average living expectancy in India has increased in the last 20 or 30 years, and so have the other causes associated with geriatric medicine. So some common procedures in the advanced is facet joint blocks. These are mainly given in patients who have back pain or mechanical pain that is due to the inflammation in the joint. So these can be performed under local anesthesia and as a daycare procedure. In early stenosis or young patients where surgery is not to be advised in most of them, or in patients who are comorbid, who cannot be undergoing an general anesthesia-based procedure, nerve root blocks can be a very good procedure which can be performed as a daycare. So now, what are the muscle powers that are there around the spine? Psoas muscle, erectospinae, and multifidus. So psoas muscle is generally not predominantly weakened because it is there, and the most commonly which get weak or which undergo diffuse atrophy and fibrosis are the erector spine and the multifidus. So what does minimally invasive spine surgery do? It reduces this tissue damage and eventually reduce the pain, and that gives you a better recovery, early rehabilitation and good function. So here you can see some of the slide which shows you the old spinal fusions or old time laminectomies which used to be done, the retractors itself was a lot of muscle necrosis which eventually led to muscle fibrosis and degeneration. The present use of dilators or use of advanced minimally invasive percutaneous screws has reduced this muscle damage and eventually has increased the outcome of the surgery. So here another, you can see the amount of fibrosis. This is 1 year post MRI, one of the paper published, which shows the amount of reduced fibrosis. So in these patients, you will see that they continue having back pain in spite of having surgery done. So they will feel that the surgery is not done properly. And in these patients, howsoever physiotherapy you advise, if there is no muscle, I don't see any increase in muscle mass that can be seen, even with rigorous physiotherapy or rehabilitation. Now, this is a slide which shows how sequentially the advancement has been taking place right from the open technique to the self-held retractors, then the tubular dilators, and now the recently used as the endoscopic spine surgery. Just to highlight, still it is not the case that open spine surgery is out of vogue. Right? So if you go to an arthroscopy surgeon, doing ACL reconstruction open is now out of vogue or obsolete procedure. But in spine surgery, till now at least, open surgery are still done, and if they are done properly, they can still give you a reasonable outcome, though not as good as compared to an endoscopic procedure. So this is a keyhole surgery or the tubular dilator surgery. Here we use microscope. Obviously, you can see the small incision which is there, and so the principle of surgery remains the same whether you do an open or a tubular one or an endoscopy. It is only the muscle damage or the injury to the surrounding nerves and vessels that is reduced. So here you can imagine the recovery is very fast. Patient can be discharged within 2 days, and he can actually rejoin his routine activities which are not strenuous within a week as well. Now, why from this tubular dilator and all this to endoscopy? Tubular dilator was good enough. It gives you a surgery with an incision of only 1.8 centimeters. So why endoscopy? The reason from a surgeon's perspective is you can see while you do with a microscope, it gives you a good vision, but the distance between the surgeon and the operating or the pathology is that much. When you do it endoscopically, you are actually looking inside the pathology. So that is the major difference from a surgeon's perspective. So this is just an animation from RiboSpine, which shows you how the tubular dilators eventually led to the use of endoscopic spine. So this is the sleeve which is inserted at the interlaminar space, and a routine endoscope. This is just similar to any laparoscopy surgery. You get the similar vision, and the principle after this remains the same: to work the lamina, to do decompression, and if required, remove the disc fragment which is causing the nerve compression. Go ahead. I have actually video of this. Huh? So this is the indication. Now this is, I think we are familiar, all the laparoscopic surgeons are familiar with this view. This is the RF. So again, endoscopic surgery uses radio frequency ablation. So the amount of tissue damage, even if it is visible, it is causing less amount of post-operative pain as compared to use of electrocautery. So electrocautery definitely causes a lot of muscle necrosis. radio frequency ablation reduces this damage as well. You can see the now this is a form of endoscopy called unilateral bifocal endoscopy which I perform. So the advantage is that you can use all the endoscopy advantages with use of routine spine instruments, so that reduces the cost, because endoscopic spine surgeries or the instruments are very costly to purchase, which eventually has to be transferred to the patients. So you can see the superficial and the deep layer of the ligamentum flavum, the epidural fat. So this is routine. This ronger is the one which we use commonly for open spine surgery. Again, like Madam was saying, this reduces the learning curve because the instruments are familiar, which we are trained while for using open spine surgery, and with the advantage of endoscopy. Now, from a surgeon's point of view, I can tell you two advantages. Since I have shifted from open, initially doing a lot of open surgeries, you don't have blood loss, because controlling blood loss, there is no tourniquet here, so there is blood loss. So blood loss control is very good. And second, obviously, like I told you, the vision, you are actually doing it where the pathology is, rather than your eyesight being here. Again, microscope availability is not that common. Even in Pune, most of the setups still don't have microscopes. So here we can do it with the routine arthroscopy instruments and the spine instrument which are there. Here the disc fragment is being removed, and this is the radio frequency ablation which is done at the fragment removal site, so it helps in healing of the annulus fibrosis. Now, this is a paper which I have published in Journal of Spine Surgery, which showed a 1-year outcome. Look at the muscle damage which is there, absolutely not visible. You saw the muscle damage or the conversion of muscle into fibrous tissue in a slide previously. So this obviously helps in long-term beneficial to the patient. Again, now coming from decompressions to fusion surgeries. This was one of the slides which you had done in fellowships. So a lot of big incision, blood loss, muscle damage, post-operative pain, as compared to now where we can put screws using the percutaneous technique, and the muscle damage is very less and the recovery is faster. Now this exact thing can now be done endoscopically as well. Very similar to what we just saw, again, use of routine spine instruments with the advantage of using endoscopic imaging. We are decompressing the lateral aspect of the epidural space to decompress the nerve root. This is using RF, so we can actually put the interbody cages using this endoscopy technique. Again, RF reduces the amount of muscle injury which is there and helps in early recovery. This is the interbody space which is there, and the shaver. This is the shaver which is being used to open up the interbody space on the disc. So the one which you are seeing medially is the nerve root and the thecal sac. This is the bone graft which is being placed inside. This is the healthy bleeding which has to be seen. If you want to achieve good fusion, there has to be bleeding side which has to be there from the cortical bone. And this is the titanium cage which is being inserted in the interbody space. Now other advances. So besides endoscopic spine, what are the other advances that have come up? Obviously, safe anesthesia techniques like use of perioperative pain management, use of various blocks like lumbar plexus block pre-operatively reduces the post-operative pain significantly. Use of intraoperative neuromonitoring has been a boon, especially when we perform the complex surgeries, because it gives you a real-time signals, or rather it gives you real-time status of the spinal cord. So it helps you prevent severe or gross problems of post-operative paraplegia, bladder incontinence, bowel incontinence, quadriplegia in case of cervical cases, navigation, 3D printing, and bone scalpel. I just rush through this. This is what, so you can see now in these cases when you do acute correction.
2 minutes, sir.
Yes. There is a need for spinal cord monitoring which has to be done, which can be done with the help of intra-operative neuromonitoring. OR is navigated used in complex pedicle screw insertion. It gives you a CR gives you a 2D image, while this provides you with a 3D image for better placement of these screws. 3D printing helps in preoperative management. So you can actually preoperatively assess what exactly surgery has to be done in complex cases. Bone scalpel, now this is a bone, you can actually cut the bone with the help of this is a harmonic ultrasonic bone scalpel. You can cut it. The best part is even if it touches the dura, it will not injure it. So the long laminectomies which we used to take around 2-3 hours, it happens in less than 10 minutes because it is just like cutting any bone with the help of ultrasound. Now, just to highlight, since this is a human head, so osteoporosis is, though it is common in males as well, predominantly early seen in women. Just to advise, we need to get a DEXA scan. We can't be just saying, okay, you are 60 and you have osteoporosis, or you are 30 and you don't have osteoporosis. If you suspect osteoporosis, you need to diagnose it. This is how you diagnose with a DEXA analysis. The various scores will be provided which will put you in a stage of osteopenia or osteoporosis. Medical treatments are available in the form of bisphosphonates, the SCRMs, denosumab, and parathormone in the form of teriparatide. There are supplements, calcium citrate or carbonate, which either can be. The only thing we need to remember is that body needs 1,500 milligram per day, not more than that. Now, in cases, just the last video, just cases where patients are geriatric and they come to you with an osteoporotic fracture, certain procedures called vertebroplasty and kyphoplasty can be done. The advantages is it's a daycare procedure, requires only local anesthesia, and you prevent all the complications of general anesthesia in a patient say of 85, 90 years. You can't put him under general anesthesia risk. And even the implants would hold because of the amount of osteoporosis which is there. So here we use kyphoplasty or vertebroplasty, where with the help of a needle under local anesthesia and CR, a needle is passed in the vertebra and a balloon is inflated, which creates the space for the cement which can be inserted. So this cement which is inserted acts as a mechanical strut and prevents the pain, especially the mechanical pain while the patient is sitting or turning in the bed. So you can see the space is created with the help of a balloon and cement is inserted in it. This is the procedure. Thank you.
Thank you, sir, for an excellent presentation. Any questions?
Sir, I would like to ask one question. If any time you have to convert for open surgery, you have to convert for open surgery anytime.
Yes, obviously. Sometimes where there are dual tears. So again, the learning curve is quite more for converting from open to minimally invasive to endoscopy. And in some cases, like for me, I can tell you during my first 25 cases, I had to convert my 25 out of 25 3 cases into open for various reasons, dual tear, or I was not able to pass the cage. But since then, obviously, once your learning curve increases, the amount of conversion, but I still explain the patient that if required, I have to convert it into an open surgery. So, like any laparoscopy procedure is going to be true, and it has to be true. You cannot. So, like I told you, open surgery is not going out of vogue as far as spine surgery is concerned in the next at least 4-5 decades. It has not gone in the last century, so it won't go.
Can we anticipate it pre-operative?
we can, obviously there are certain cases like a very high grade dystosis or where I require a posterior vertebral column dissection. I don't attempt endoscopy. So I tell the patient this is not to be done endoscopically and I am comfortable doing it open. If you want, I will do it in open or else I can't do.
Thank you.
Now I request organizing chairperson Dr. Meenakshi Deshpande to felicitate Dr. Shardul Suman and I request chairpersons to join the felicitations.
Thank you.
The next speaker, Dr. Suprashant T. Kulkarni from Lokmanya Hospital. He is MS Surgery and a fellowship in FICS, FALS, FACRSI, FMAS, FIGES. He is Senior Consultant Surgeon, General Gastrointestinal Laparoscopy Colorectal Endocrine Surgeon. He is working at Lokmanya Hospital for special surgeries and Lokmanya Hospital, Nigadi, Pune. His special area of work interests are Chief Trauma Surgeon for Trauma Unit of Lokmanya Hospital. He is faculty for Laparoscopic Hernia Surgery Training Programs for Surgeries. Center of Excellence for Laparoscopic Hernia Surgery Training. Special interest in abdominal wall reconstruction, hernia, upper GI, and colorectal surgeries. Dr. Suprashant D. Kulkarni, please.
Thank you, chairpersons. For the kind words. I thank the organizing committee and my hospital for this opportunity given to me. So any topic of evolution of surgery. So any topic is not complete without looking back and understanding what was done earlier and how the science has progressed. So if we see ventral hernia, which means that any hernia arising on the abdominal wall in the midline or on the lateral side, the commonest ones being the umbilical hernia, epigastric or intra-umbilical, and due to advent of multiple surgeries, the incisional hernias. So these all constitute the ventral hernias. So if you see in the 1800s, before 1800s, the only treatment was giving a binder. There was no other treatment because by that time nothing was invented. So history of ventral hernia surgery is pretty recent. Whereas for inguinal hernias, there's been a lot of history. Whereas this is quite recent. So after 1800s, the surgery developed along three lines. Simple repairs. So the first person who's mentioned in the literature is Gosselin, who defined the anatomy of the abdominal wall, and he designed a simple procedure of transcutaneously suturing the defect. So he did not open the abdomen, he just transcutaneously tried to suture the defect. Obviously, the recurrence rates were almost 100%. Then there is a French surgeon who to try to separate the abdominal wall and repair it layer by layer. So this gentleman is the first one who defined what was real limitation, that is ballooning of the abdominal wall, especially after pregnancy in women due to lack of exercises and the actual incision of hernia. Then there were a lot of evolutions, and Mayo in 1901, he published his West Coast umbilical hernioplasty, which is being still followed. So what we do in that is we repair the two edges of the hernia defect by multiple sutures. Now, then as the size of the defects increased, the need arose to repair that defect because it could not be done locally. So then people used what was available locally, that is various tissues, muscles, fascias, cartilages, even meningeal flaps were tried, but obviously all this did not give rise to expected results. There was also attempt at heterologous tissue transplant, that is from other species. However, everything failed. So then came the era of metals. Metals, there was industrial revolution and various metals were available, gold, tantalum, and ultimately stainless steel wires were used, and they are still being used for inguinal hernia surgery in one of the clinics in Canada. However, for ventral hernia surgery, the usage of stainless steel wires is now almost non-existent. The important development was from 1940s, where people started using nylon meshes. There was chemical revolution, and we could get synthetic material for putting as a patch. And then there were surgeons who observed that when you put intraperitoneal nylon mesh, a typical debris or exudate will cover the nylon mesh so that it becomes a lot safer. And Dr. Francis Usher was the first in 1950s and 60s. He worked with various chemists and engineers to develop the first polypropylene mesh. And the importance is that it radically brought down the recurrence rates down to 10 to 20% from the earlier data or earlier figures of more than 80%. And his patented mesh is still being used by surgeons. So now we had a defect, we had a mesh. Now where to put the mesh? So there are layers of abdominal wall, as we all understand. People tried putting on the aponeurosis, that is on the external oblique aponeurosis, or on the linear one, that is called onlay. But you required a wide dissection. Due to wide dissection, there were a lot of seromas which ultimately got infected and caused problems. Then people thought of putting the mesh as a bridging repair or the inlay repair. That is, you put a mesh between two edges where the defects are very big. However, again, as you can understand, that hence any hernia is a battle between intra-abdominal pressure and our repair. Obviously, a person who has exert pressure for his daily activities like coughing, sneezing, constipation, motion, urine, there is going to be a continuous pressure. The inlay repair also gave rise to a lot of recurrences. And then there was underlay, that is putting the mesh inside the abdominal wall. Like you put so that repair, which was earlier used in 1940s, the problem was polypropylene mesh or polyester mesh was also being developed that time. There were a lot of bowel adhesions. So this led to problems. These are important people in the history of hernia surgery. Dr. Jean Reeves and Green Stoppa. Green Stoppa invented the inguinal repair, wherein preperitoneal retromuscular space was used to put a large polypropylene prosthesis. So it was found that if you put the mesh in preperitoneal retromuscular space, it has got a lot of advantages. And that has become almost a standard of care now. What are the advantages of sublay or retromuscular preperitoneal space? One is there is very good vascularity. which takes care of mesh integration. The mesh gets integrated into the body very well. Hence, the formation of seromas or any surgical site occurrences and infections is very less. The risk of adhesion of the mesh to the bowel or bladder or getting fistulas is almost nil, unless, of course, there is suture line dehiscence or something like that. The recurrence rates have been found to be the least with this plane. And most important, the use of a large mesh in the intramuscular plane, you do not need to fix it because the intra-abdominal pressure will force it against the muscle and it will keep it there. Whereas if you put a mesh on the top of the abdominal wall, it is like plug in the bathtub. If you have to put a mesh, put a plug onto a bathtub, if you put it from inside, the pressure of water will make it little more tight. If you put it on the outside, the pressure of the water will make it to go away. So that is difference. Then there was development of laparoscopy. Lap chole was done, laparoscopic appendicectomies were done, various gynae procedures were done. And in 1993, there were attempts at putting in intraperitoneal mesh. So initially, the mesh used was because they understood that there is a problem when you use naked polypropylene. But by that time, they had PTFE meshes. So a PTFE mesh was used from inside as a patch, and it was fixed with sutures or tacks. The problem was earlier tacks were very crude, so there was a lot of pain, problems with migration, and again the problem was if the defect was big, the mesh required was very big, because there is a recent paper which says that the ratio between mesh and the defect should be 1:9. So if you have a 2x2 defect, you require in the proportion 4 into 36 square centimeters mesh you require. So if you have got a large defect, again doing intraperitoneal repair and putting in that mesh plus the cost of the mesh is a big challenge. Then the development was in 2000s, people started repairing the intraperitoneal defect from inside and then putting a mesh, which to a certain part solved the problem of putting in a large mesh. But however, the risk was again, even if you put a coated mesh, these are not simple meshes which are used, either they are totally transparent, totally other than like PTFE, or they are polypropylene meshes coated from inside so that there is no bowel adhesion. However, the coat which is given, sometimes it is collagen or other materials, gets dissolved in 3 weeks. And there are instances wherein people have had encountered bowel adhesions and other adhesions. Luckily, the risk of adhesion is much less, but still the risk exists. Again, the problem is with the cost, because a simple polypropylene mesh, say 15 by 15, will cost 3,000-4,000 rupees. A similar double coated mesh will cost 35,000 rupees. Plus, you require a tacker to fix the mesh, that costs another 25,000 rupees. So, an open surgery, the cost is suppose 3,000-4,000 for the disposables. Herein the cost of disposable is 70,000. Again, in open surgery, you need you can do it under the regional anesthesia. Here again, we need general anesthesia. Plus, the time taken is little more in initial period compared to open surgery. In case of large defects, so big defects more than 5 centimeters require additional help. So these are the challenges which were there and people were trying to focus on these. So what were the newer challenges? There were rising number of complex abdominal wall defects. This is because the age, the speakers have already outlined the age we are living more and more. That's why there is increased rates of obesity. The people nowadays don't die because of starvation. They are dying because of excess of food, because of various reasons. So there is increased obesity. There are increased defects, increasing diabetes, leading to a lot of post-operative problems. Lot of critically ill patients, especially patients with complex abdominal conditions, because of advancements in critical care, they are now seeing the end of the day and they are leaving. But whenever patients undergo very severe surgeries, especially the damage control surgeries, they are left with large defects, and then it's a challenge to repair these defects. Then there are loss of domain hernias. So loss of dominant hernia again requires a complete lecture, but when a person has a hernia, there are two important problems why one should get the hernias treated before they are symptomatic. One is the risk of complications, standard complications, which you already know, obstruction, strangulation, and so on. The other is progressively the hernia, because of rising intracranial pressure, the bowels are pushed outside and the surrounding muscle becomes atrophic, and gradually more and more bowels go outside, leading to something like this, wherein, so this is a lady whose hernial contents, they were 55%. So when I did her volumetry, the ratio of volume of the sac to the ratio of the abdominal wall is almost 55%. So if you put them all back in one go, the problem is they will not go. Second is it will cause abdominal compartment syndrome, which will lead to vascular compromise and the patient will not make it. Third is when you put them all together in one go and try to put them together, it may be possible on table because of GI and relaxation, but then the patient will not be able to breathe because that is going to give rise to more pressure on the diaphragm and the patient will be on ventilator. And this is a very special case. There are a lot of people who are obese and weak, and this lady was treated at her hometown for 20 years, and until she came to us with such a huge hernia with strangulated bowel. So she required surgery. We operated her, resected the bowel, and when we, because it was a resection, the defect was too huge, it was decided not to do anything, repair hernia at the second instance because it is impossible. But the large sac derives its blood supply from surrounding structure. So when you put everything back, the skin gets necrosed, and then you are left with a huge defect on the abdominal wall. We don't know what to do. Other important challenge is diastasis recti, especially in women. That the linea alba becomes wide. Normally, up to 2.5 centimeters width is considered normal, but if it starts going beyond, it is called diastasis. And there are plastic surgery methods to repair that if the patient is cosmetically concerned. But when it is accompanied by a hernia, most commonly umbilical hernia, you have very good laparoscopic solutions to treat these. Now, simultaneously, when the things were developing on the mesh front, better prosthesis, there was improved understanding of the abdominal wall. Now, this is, you can see a standard teaching which was taught to us in the medical school, that the rectus muscle is enveloped in rectus sheath, anterior sheath and posterior sheath, and all the oblique muscles, they come from laterally, they fuse at a line called linea semilunaris, and then they give an envelope called anterior rectus sheath. Anterior rectus sheath is formed by external oblique and internal oblique, and posteriorly there is a capsule covering called posterior rectus sheath, which is formed by the internal oblique and the transverse abdominis. So it was believed that all these oblique muscles, they end at the lateral edge of the rectus muscle, which is called linea semilunaris. However, in 2006, so this we can call that as a landmark development. It was understood there were, and this gentleman, Dr. Yuri Nowitzki, is the one who understood that it is not that all three fuse. In fact, the transverse abdominis muscle extends just below the rectus muscle. So it doesn't end there. Fleshy part of transverse abdominis muscle is forming the posterior wall of the posterior rectus sheath in almost the upper third, and the aponeurotic part is a forming part of that in the lower 2/3. So how this is useful will come to know. But understanding that abdominal wall is important, because what are the functions of abdominal wall? Because abdominal wall is the least understood or least cared for structure earlier. Surgeons, especially big surgeons, used to take big incisions. So the bigger the surgeon, bigger the incision. And reconstruction of abdominal wall was not so much important. So for what are the functions? It protects the abdominal organs. The back muscles, they provide stabilization to the spine and pelvis. They help in breathing. They help in generating valsalva, which is required for various body functions like coughing, passing urine, defecation. The abdominal wall helps in rotating the torso and other functions. And ultimately, it's also important that if there is no intact abdominal wall, the sense of satiety may be hampered. And if the sense of satiety is hampered, the patient may gain undue weight. So,
last 3 minutes.
So it was important to restore the continuity of the abdominal wall, not only restore the continuity, but also to reinforce, because the rate of recurrence was high because of lack of enough tissue. So the techniques developed were posterior component separation, wherein you can see that the part of transverse abdominis muscle is cut here, and you get access right up to the kidneys. So the case you saw earlier, in her case, because the total sac volume was 55%, it was impossible to put. So the first step was I administered her Botox, so that it is administered 300 units under ultrasound control, which leads to relaxation of the abdominal muscles. It is injected at 9 points, and then after a couple of weeks, she is taken for preoperative pneumoperitoneum. That is, we take her into the theater, put in a diagnostic laparoscope, see all the insides, remove the adhesions, and then keep a catheter inside, so that daily afterwards for 15 days we instill 1,500 ml air, so that there are two functions with this. One is stretching of the abdominal wall, the paralyzed abdominal wall because of Botox, and then the patient undergoes, this patient underwent posterior component separation. The steps are seen here. Wherein this is the rectus muscle and this is the posterior rectus sheath. When you take cut over the posterior rectus sheath, there are two important structures: the internal level of the internal oblique and the transverse abdominis muscle. Once you cut them, you get an access to the retroperitoneum. And here you can see, you can get almost a bridging cover of 5 to 10 centimeters each side. And this way, here you can see that we have reached the kidneys. Here you can see the ureter. So this is how you go, and in this you place two processes, 1 foot by 1 foot, so that it covers right from zippy sternum to the pubic symphysis, and the pressure is monitored, so that we don't have rising intra-abdominal pressure more than 6 centimeters. So that is continuously monitored. And this you see after you reconstruct the abdominal wall, the appearance at the end of 6 months. The patient is doing all the activities. Now, in case of such wide defects, it's a problem what to do. So herein, she was worked up. When we removed her necrotic skin, there was nothing there. So she underwent 4 months of VAC treatment. So it is specialized VAC. She was in the hospital for 4 months. We put in the VAC, that is vacuum assisted compression, and at the end of 4 months, the edema was decreased, and then I could breach her. So this was a temporary composite mesh used to repair the abdominal wall using elongation techniques. Here the posterior component separation was not done, but in this case you can see that the patient is very good. We can have a good life. And have just a short video of ETEP RS. Now we have already seen that Reeves Stopa hernioplasty or retromuscular mesh placement is the surgery of choice in open hernias. So when you have a laparoscopic repair, to avoid that open access, the advantages of open access. So this has proved to be uniquely advantageous in giving the advantages of open surgery with laparoscopic access. And this has been brought into, this is developed as recently as 2015. So here, first port is put through the retromuscular space in the left
video is not,
margin.
Doctor, your video is not running.
the last.
Till the technical glitch is over, I'll just like to make a comment. What Suprashant Kulkarni is trying to explain is the older concept of putting the mesh over the abdominal wall is no more valid now. We prefer to put meshes in the retromuscular plane or inside the abdomen. So this is a technique where we put in the retromuscular plane.
Perfect. Like Dr. Kedar said, this is the order of the day now, and here in. So this is umbilical hernia. These are the markings for linear and cellular lines, and the port is taken here. You can see with the help of 4 ports and just rush to the dissection. This is the retromuscular plane which is being developed on the left side. This is the posterior rectus sheath, and that is the rectus muscle above. So you create retromuscular plane on left side. Additional ports are put, and this is the important step wherein you have to cross over to the opposite side, to the opposite rectus muscle. So here we are looking medially towards the midline, and this is the anterior, the medial margin of posterior rectus sheath. So medial margin of posterior rectus sheath on the left side is being incised to get access to the pre-pectoral plane in the midline. So this is the pre-pectoral plane. Above lies the linea alba, below lies the falciform. So once you enter the pre-pectoral plane, you can see the opposite sided rectus muscle. This is the pink thing, if you can see, which is seen in the opposite side. Now we open into the right sided sublate space and develop it, and just rush through. These are the neuromuscular bundles which have to be preserved, and here I am developing the right sided retromuscular or sublate space. Now this is the linea alba in the center, this is the umbilical hernia, and now both sided posterior rectus sheaths are being cut as we go down, so that we ultimately have a single space on both the sides, which is done in the open surgery. So here I have dissected all around till the infra-umbilical pre-pectoral space. In the distance you can see the Cooper's ligaments, but there is no need to dissect them like in inguinal hernia surgery. And here you see the defect of umbilical hernia. The underlying omentum is checked for any problems. The defect or the rent in the linea alba or the hernia defect is sutured by a braided suture, barb suture, and you close the hernia defect as well. So once you suture the entire anterior abdominal wall, then you close the peritoneum. So you have entire space from top to bottom. The length is measured by using a scale, and a large piece of mesh about 15 by 30 centimeters is placed inside the retromuscular plane. Now this has the advantage that the mesh does not need fixation because it's a large mesh. The pain hence postoperatively is minimum, and at the end of the day, once you desufflate, you will see that you have only 4 sutures. The patient, 40% of the patients go home on the next day and rest on the second postoperative day. And believe me, these patients, they may have multiple defects or a single defect. They behave the same. You can see the umbilicus also tucked in well. So this has been an excellent method of repair. I'll just show you another small video just to show that this particular person, you can see the mesh, and he had multiple switch defects. So previously he was repaired 2 times and mesh inside, but the technique remains the same. You repair the defects, repair the wall, and put in a large mesh. Yes, it's done. And the result is the same. So I thank you for patient listening.
Thank you, Dr. Suprashant Kulkarni. For the want of time, we are not entertaining questions. Only thing I would like to know morbidity and mortality of these cases.
That is an excellent question, ma'am. Surprisingly, the morbidity of retromuscular repairs has been the most, least amongst all the repairs. The only problem with this repair is because it is a retromuscular repair, it requires technical dissection. So it requires little more time. In the learning curve, people will take 3 hours. So people who are suitable for this procedure, they have to be well selected. You don't select morbid cases. You select good cases which have endurance for to undergo 6-hour surgery. With now more than 200 cases under my belt, my operative time has now come down to 1 hour and 15 minutes. However, time of surgery is not important. You have to choose the procedure according to the patient.
Selection of the patient is important.
Very important.
Thank you, sir. We'll proceed with next lecture.
Thank you. May I request our chairperson to felicitate sir.
इकडे समोर. Thank you.
Thank you, sir. My request, the next speaker, Dr. Mammogram, sir. Is it there? Yeah, please. There is a gynecologist, endoscopic surgeon, walking in our hospital. I don't think there is any introduction necessary because he is well known in my field. Please, sir, take over. Thank you.
Hello. So thank you so much for the kind words. Yes, I am covered by not studying my teachers. I think many people are free and having their lunches. It's okay. I take this opportunity before starting my talk to thank our chairperson and this is an excellent opportunity for me to talk in front of you about this recent advances in gynec laparoscopic surgery. So probably I hope I'm not repeating the things which have been covered or actually people know most of the times. This is what we know, that this was the biggest, I can say, like this is the biggest advent when there was laparoscopy or endoscopy involved in surgical practice. In gynec, it is now something which call it like except cesarean section, everything can be done with laparoscopy or endoscopy, including histoscopy. So that is what is the opinion at present about gynec laparoscopy. When we start about recent advances, we cannot forget the past. He's the person who guided us throughout his career, throughout his life, and till all the instruments and everything devised by him had been very useful and up to date for our present gynec practice as well. He is Dr. Coach Singh. And this is what I have written about him. And I know about his history, that he was a gynecologist. He started very quickly about this scopies. He started trying seeing in abdomen, in thorax, everything, and starting upgrading the diagnostic process into laparoscopic surgery. Once he demonstrated laparoscopic appendectomy to Society of Surgeons, and then he was actually recommended his gynec practice license should be removed, and he has to show his brain scan so that he is normal. So that much of resistance you may get from one if you are little extraordinary in practice. He has devised the pelvic trainer. That is one thing which we will talk about it in the later part of the talk as well. But he has devised pelvic trainers. He has devised the laparoscope. He has devised the laparoscopic instruments like scissors, graspers, then the cautery machine. They call it like thermocoagulator. So that is also devised by him, who is just modified little bit to have monopolar current, bipolar current, and modify that current to our purposes as well. He devised needle holders, the suturing techniques. It is always like I usually feel that laparoscopic suturing is little height and made it difficult. It is nothing more than a normal suturing, but still the idea of doing it inside with two fixed points for the instruments was by him, and there is nothing has changed in that as well till so far. And here you also like suturing the wall, the peritoneum, uterosacrals, right side you can see the suturing of the uterine artery as well. So this still you master and you have everything in surgery. Whenever I started learning laparoscopy, I was of the opinion if you can open or excise or do all those things, you should be able to close as well. So I moved to Bombay and learned using laparoscopy. But what has changed in laparoscopy, like advances, what we call the advances is this. The concepts about surgery have changed. The pelvic spaces. We know that our surgery in gynec, where like 3.5 surgery we used to call it, hysterectomy or whatever surgery we do, gynecologist always used to do is like little coordination, like staying very close to the uterus, staying very close to the ovary. Don't see beyond that. Never think about anything beyond the peritoneum. The imaginary fears of ureter and bowels beyond the peritoneum. But it is not the case. Nowadays everything has changed. This is I would call it like previous. You can say normal practice, recent advance in that. The technical advance is different story. But this is the recent advance in our gynec practice because the number of cases what we see, the type of cases what we see are absolutely different nowadays. Maybe because of the available modality, you can say sonographies, then MRIs, and the diagnostic scope, which is at our disposal anytime. So, incidences of endometriosis, increase. Everybody calls like but it has improved because of this modality that we know. This concept of pelvic space is always there. It is not like new thing. But it is now very routinely used in our gynec practice because for any normal surgery as well, there was a thing that line ligating the uterine artery also, which I have tried also. And after doing few, like you would say, like 100 of cases, I thought there is no need of doing that. It is not that every time that recent advance has to stay there. For the idea which is thought about, it is not like that. If it is really there needed, then you should do it. That is what I thought about the learning of laparoscopy. This is again the thing where we dissect the ureters, the spaces around. There are spaces like 4 spaces around the bilateral and 4 spaces anteroposterior single spaces. Nowadays, the concepts are changed. Like it is not only oncosurgery that will be oncosurgery who will bring cancer cases. Gynecologists also have the training courses about onco, and they are also into this surgery. But endometrial is something like not cancer, not benign kind of condition, but still it is covering a lot. So we are into like into a suit that what we should do. But we have trained ourselves tackling all the bad endometriosis in laparoscopic way. This theory about this like lateral pararectal space, medial pararectal space, is called dead slow space, space. All these spaces they have to be very careful. And I would say, I would not hesitate to say that cancer surgery in case of cervical cancer or endometrial cancer, those cases are that way they're okay to operate laparoscopically than endometriosis because the surgery is difficult in endometriosis. That is the state. Why? Because there are a lot of adhesions. There are a lot of fibrosis. All things are stuck to each other. The things are coupled together. Ureter from the lateral space may come to the uterosacral and close to the bowel at the uterine. And when you are releasing those things, you look at the ureter. That is how it goes in endometriosis. That is why endometrial surgery is something like you can say like in vogue at present, you can say. And the way of doing it is something which is rapidly changing. So these are all the pelvic spaces and our concept about that. Ureterolysis is now actually a basic part of any surgery nowadays. Any ELH, difficult ELH, you see the ureter and go. Broadly and fibroid, you see the ureter and go. So our first thing, what we do now is like pull the pelvic ligament, open the catheter space, and see the ureter. That is, to be frank, it's actually like 30 seconds or 1 minute of when you see the ureter after opening the parietal space. So this is the concept which was not there previously. That's why I'm repeating it repeatedly that previously it was always hug the uterus and go and progress in the linear surgery. That is not the case now. It engulfs very badly. Endometrius engulfs the ureter very badly. It can be extensive endometriosis, like spreading around the ureter and causing it compression. Or it can be intrinsic. I mean, like it spreads through the wall, like affects the wall of the ureter and infiltrates into the wall and gives severe pain. So that part of tissue is actually affected. It is not only constriction by the surrounding tissue. So that time you have to cut it, excise it, re-implant it. So that is all parallel and near to the gynecologist as well. Like everywhere you don't get neurosurgeon, but as a medical purpose, it has to be there with you. That is the recommendation. But if you land up into problems, you should be able to suture the bowel and bladder and ureter and I would not easy to say you can do it because chemoplasties we are doing regularly. There is like suture is 60 and 70 rolling or like the tube is supposed. So that is not a very difficult job actually. We have actually that is an acquired skill for us at this point. So that is how the character space is seen. Once you open, the things are there in front of you. Ureter is there, uterine arteries crossing the space. Then you take the anal ligation. So internal ligation is a very big thing previously. That is a very good thing nowadays in our gynec surgery as well. And to go ahead, like in obstetric cases as well, sometimes it can be done in PTH, like the uterine artery. This is integrated into it with laparoscopy. Your time and the conditions permit. This is a paravascular space. I would just skip this because this is again a part of that concept only which has changed. It has got its own significance. I mean, like in cases of say exposing of nerve, or in cases of difficult bladder, or in cases of previous 2, 3, 4 LSCS, that time you cannot go from above down. You can go, but if you have to go safely, you go beyond your bladder from the lateral space, that is paravascular space. Go and see, and then it will really come up, and that those area you can tackle, knowing that what is above and what is below. So then you can cut it into that proper place. So that is the concept of having knowledge about the paravascular spaces. Vesicular spaces. It is not only to push the bladder and keep the things ready for hysterectomy. Now it is for native tissue repair of the cystosis. Same thing posteriorly as the rectovaginal space. You can do this puckering or whatever kind of features that you can see there, and you can do native tissue repair of the cystosis. Why it is required? Because for the future delivery and everything, if you put prosthesis like mesh or tape, then it may cause problems. That is why this concept has come up, and it works very well until at least it delivers. Because with delivery, there are a lot of changes in the tissue, so it may make a you can say deteriorate, but until that time it can be easily done with native tissue. This is one concept which is there, like very aggressively progressing the subject, and then suddenly there is some problems, complications, and you revert back to something which is basic, not principles of the subject. It is the same thing. I mean, what the prolapse has been. There's a trend that putting mesh everywhere in the pelvis, but looking at the concept and complications of mesh, then we are again coming back that whatever is needed or required, that much only you do. You don't overdo the thing. You are treating the prolapse as well as the condition. Like when until the patient complains of prolapse, something is coming up, you don't go ahead and go and hang the things out. If she's not complaining, don't overdo the thing, because there are always complications associated with some surgical procedure. So this is a technical ligaments, you can see from the word for that. Nursing tape is used for that. What coming out, it has been pulled up, tied to the pectoral ligament. This is also the concept of say lateral pelvic spaces as well. We are not going there all the time, but when we are aware about this anatomy, then we can easily do and pull the tape or mesh if needed. Sometimes you don't have a tape because of scarcity, that you can do it. What has changed in laparoscopy? So this slide is only for that our coverage also has changed. What is seen in this film is actually the repair of the utrovesical fistula. Utrovesical fistula, it is different. I will not run the complete film, I will just take it ahead. I will tell you the story. This is the advantage of knowing the paravesical space. You open there, you go below the fistula, you can say like fistula opening of that track. You go below that, you know the above things, and then you match those things and divide the bladder anteriorly and the vagina posteriorly. That is how the concept of spaces help. But this was the case, very different case. This is not regular vesico-vaginal fistula because of say most of the time because of TLH or some laparoscopic gynec surgery. This is because of obstetric. She had prolonged second stage, and because of that, the sloughing of the uterine tissue and the bladder has occurred, and the fistula has occurred. She was from some place where she was not having access or not having awareness about these things. But later, when she came, we offered this solution, and it could be done laparoscopically. Anyway, it can be done open way as well. But this is something what I want to tell you that recent advance is that your courage is in this when you are aware about the anatomy and the instrumentation what you have. You are seeing the harmonic circle here, ultrasonic, fantastic instrument for dissection, gives simultaneously the hemostasis as well, and very less damaging to the tissue. It is not like a very high current where lateral thermal spread is too much and you get fistula because of that. It is not like that. It gives very gentle kind of dissection and the hemostasis. So it is dissected now. The bladder is anteriorly, the defect in the bladder is seen there. Posterior uterus, and suturing is not only like you close the bladder and you close the bladder. It is not like that. Now our task was to connect that cervix to the uterus as well. And for that, as I said, that suturing is actually the acquired skill. So here, for that purpose, usually anybody will put the dilator in the cervix and the uterus and the suture on that. But with your scope in this direction, your instrument in this direction, it becomes a bit difficult to suture it. So what I have done is I put the Foley catheter from the cervix to the uterus so that uterus can be bent like this as well. Because it is a flexible thing. And you can have things in front of the scope. And then you can suture it. So that was something. So these are the things. It is not like big advance or something, it's just a common sense. This is the excision of the fibrotic tissue, and then it was sutured. Momentum was kept on that. So the message from this is that your courage increases with your skill and the backup of your instruments and understanding of the anatomy. We just move to the next concept. What has changed? Again, this is another change which I will tell you, that the laparoscopic burst of the suspension. It was very aggressively going towards the meshes through the vagina, meshes through the pelvis. But again, the combination of meshes which were put from below, like vaginal side. So that causes a lot of complications. Gynecologist and urogynecologist from America, he had shown some photographs and complications of this thing. Mesh complications, like half thigh of the patient had been necrosed and all those things. So those things, if you see those pictures or something, you will be very scared about the meshes. This is what we do in laparoscopic burst of suspension. This is the condition after dissection, and this is how we pull the vagina just at a level of bladder neck and tie to the pectoral ligament. So knowledge of anatomy and the spaces useful here, yes, very useful, and dissection skills as well. So this is actually a film Just take it ahead. This is the film of burst almost suspension. Here we are working again in the same case of previous and parasitus. This is the pectoral ligament getting exposed. Then we dissect the bladder away from the vaginal walls, medially, make the vagina prominent, take a stitch and tie it, hang it to the pectoral ligament, bilateral. That is the burst almost suspension. Why I am showing this, talking about burst almost suspension is because these meshes cause so much complications. So we are again reverting back to our basic surgeries, burst corpus suspension. So it is the thing that is advised nowadays. Those transvaginal meshes are actually withdrawn from the market. They are in bad repute and sometimes they are not available. Only something very small mesh is available. But again, everybody is scared of all those things. Patients may have pain continuous there. And so we are again back to the burst corpus suspension. So this is the future. At this moment, what we are seeing here, unless we get something more, something different than what has been done so aggressively in the last few years. So we are again now staying on the bus for a few days. This surgery can be done for second degree cystoscopy as well. It takes care of that. This surgery can be done with hysterectomy. This surgery can be done with any other pelvic surgery like myomectomy, and there is some cystoscopy or there is some stress incontinence. Because the stress incontinence, if you ask me, and now everybody knows that. Somebody has said that the world is divided into two. The females are divided into two. Like who have stress intolerance, who don't have stress intolerance. That much common it is, but they don't speak about it. That is why we have to ask and give relief to them about this surgery.
Excuse me, sir. 5 minutes more.
5 minutes.
Yes.
This is something what we have started doing few years back. That only our transvaginal encerclage was known to us. But nowadays, the repeated means the condition is same. The repeated miscarriages. But we are not very keen doing anything abdominally. Usually big cut and all those things. But the same thing can be done laparoscopically. Then what is the heart? Or you can say contribution of anesthesia, contribution of or other faculties has made it very possible that you do laparoscopic cerclage and give good relief. Why? Because these are the three levels where we work. So these are the levels. The uppermost is where we do transvaginally, that is laparoscopical, and you can give relief. We have very good results. People have delivered after delivery with severe section. It has been delivered, and advantages are that it can be used for your next pregnancy as well. So your miscarriage rate is less. I'll skip this slide. This is about some myometrial cyst. It is not always the cystic adenomyosis or something, but this is myometrial cyst. Your teenagers come with severe pain and you don't find anything. There may be just very small cyst which sonologists may have missed or something, and that gives an excruciating pain. And just remove that one, excise that one, and she gets completely. I had almost 5 to 6 patients like that. Teenagers and then later as well. There is no endometrium. You always suspect of endometrium, but it is not there. So that is myometrial cyst. You have to excise it completely. Otherwise, it will recur. Because other pelvis was absolutely clean in this case. The advances are seen or classified, you can say like this. We will read that. Preoperative evaluation of laparoscopy. In which fronts we are talking about advances? Preoperative evaluation, like good 3D sonography we have, good normal sonography you have, then MRI you have. Those investigations will make it possible that you know where are the inverted nodules, how many fibers are there, where are they located, is it possible to do conservative surgery for that? That is preoperative evaluation. How much depth is involved in endometriotic lesions? Then devices and techniques. Different locals have been divided, but all are same. That is the same. There is no advantage of each in oxygen laparoscopy, that has changed. It has been suggested that you do contain oxygen, impact the oxygen, because there was a case of spread of cancer or something. But it gives advantage, so you should adopt that and use it. Like impact oxygen should be adopted. Perhaps you have changed the suturing in laparoscopy a lot. Your time has reduced to, you can say, like 1/3 of the surgery, because that suturing takes so much time with non-barb suture, but with this, you can just finish. If I see my film of mammogram, it is like with normal, if it is 4.5 minutes, it would be like just 2 minutes if you double the speed. So that is how it has become so fast with barb sutures. Then advances in active surgical approaches. They must have heard about robotics. We always think of robotics. If it is advances in surgery, what comes to our mind is robotic surgery. But apart from there are two things like single port laparoscopic surgery, single incision laparoscopic surgery. There are two different things. Only thing that incision at one place and you operate through that with 2-3 instruments with that. Then we know do laparoscopic surgery, but your scope and instruments are going through the vagina. So it is we know. Then something in the post-operative period as well that enhance. You can say that enhanced recovery after surgery. A few things you change, your carbohydrate intake, your hydration you change, and there is tremendous change in the recovery. That is what suggested by actually the literature. The people have done some research and done that. Then education in laparoscopic surgery. Laparoscopic surgery can be learned with assisting by assisting somebody, but still there are many things to be done. As I quoted in the initial part, that first thing that you have pelvic tendons. He was appropriate. It has to be done with your own hands. Then only you can learn it. But the advances has gone to simulators and augmented reality and artificial intelligence, and everything has been utilized for learning and the training of the people in laparoscopic surgery. I will skip few slides here. But actually, mammogram I will not go into because it has must be covered that.
Sir, please wind up. Because we are getting too much late.
Right.
Mr. Bureau would like to have your session throughout the day, but the time is limited. So, yes, yes.
The time which I started was a different too, but still I would conclude. Thank you so much. Thank you so much.
Thank you, sir. Thank you. I will request now our Executive Trustee, Dr. Sanjay Patil, sir, and our Treasurer, Dr. Sudhir Indre, to come on the dais to felicitate Dr. Mahendra Gossi, sir. And both the chairpersons, three of them to join this felicitation.
Next speaker, I would like to invite Dr. Sumi Shah, who did DNB in General Surgery, DNB in Surgical Oncology, Fellowship in Laparoscopy and Robotic Surgery. Presently, he is working at Pro-Life Cancer Center, Pune. His special area of interest, organ and function preservation surgery, minimally invasive cancer surgery, and his hobbies are reading, trekking, and music. I request Dr. Sumit to give his presentation.
Thank you very much for kind introduction, and I would like to thank my previous speaker for showing all the laparoscopic skill, and he personally agreed that oncosurgeons are very. I think any surgical, to be very honest, any surgical skill you acquire with hard work and practice. My intention here is to focus on prevention and what are the minimal advances. What is prevention is in oncology, and if you see gynecological malignancies and female malignancies, majority of them are And before starting on prevention, we should know how severe the problem. If you see the 5 most common malignancies in female, they are breast, cervix, ovary, oral cavity, and bladder. Means in 2018, before 2018, cervix cancer was the most common malignancy in rural India as well as in urban India. Gradually, breast cancer became most common malignancy in urban India, and now it is most common malignancy all over. And in the world also, it is the most common. Now, second most common malignancy is cervical cancer. If you see cervix cancer, it is actually a vaccine preventable disease. Unfortunately, still maximum women die because of cancer in India, cervix related. So a disease which is vaccine preventable, we are not able to conquer. That is the real unfortunate thing, and we should focus on this. Ovary, unfortunately, we don't have any modality to screen this disease. Now, I want to underline the importance of oral cavity malignancy. See, oral cavity is the 4th most common cancer in India. Urbanization has increased, incidence of smoking and alcohol use in female has increased, and naturally colorectal cancer. Again, colorectal cancer is also a preventable disease. Doing just a blood test after the age of 45 every year has shown to reduce colorectal related mortality by 30%. So these are the figures. What is unfortunate about India is age group in which we detect cancer in India is 30 to 69, which is the most working and most productive age. Majority of our females present at in the 16% of our breast cancer present between the group 30 to 40. So when we see compared to the West, median age of breast detection is post menopause, that is after the age of 50. But in India, median age at the diagnosis of breast cancer is 47, and 16% they present between 30 to 40. Means many times we get patients who are under IMA treatment or some other during their pregnancy, and they have come and they are missed. So regarding breast cancer, most important thing is breast cell. After the age of 25, all the females should start to understand their own body, their own physique, and they should do breast self examination in front of them. Those who are menstruating, they should do 3rd or 4th day of menses. See the breast segment, whether there is any pimpling, discharge, any change in the skin, and squeeze the nipple and see whether there is any discharge. If there are these signs, they should immediately consult their physician or gynecologist. Mammogram. Actually, if we see advances in the prevention in breast cancer, this is the mammogram. Last 50 years, we have seen mammogram has prevented 33% of death in West. And if you see NHS means UK, screening mammogram is mandatory. If it doesn't do screening mammogram, it doesn't get any other insurances. So mammogram is mandatory for all people. Unfortunately, our health priorities in India are different, and we all need to do opportunistic screening. Patients come from the other region, we should advise mammography if the patient is about to. So, screening mammography is very important, and opportunistic screening means patient may not come to you for breast related symptoms. They may come to you for viral fever or any other problem which your specialty is. But you should advise mammography if the patient is about to. So, if you see there are studies, median size of disease in India is approximately 40 centimeters. In US, it is 2 to 3 centimeters. That is UK, it is less than 1 centimeter. So, if you detect breast cancer at an early stage, how the advances are there in the treatment evaluation? So, breast cancer again, from radicality, open surgery to laparoscopy, from radical surgeries to organ and function preservation surgery. This is how we are doing. Now, we know cancer is a curable disease. If we change that mindset, then we go and focus on quality of life after surgery. So after cancer surgery, if we focus on the quality of life, it is under the body self-image or psychological impact of a female when she goes through her social life, her familial life. In older days, people used to do wear halster radical mastectomy where entire breast along with muscles and lymph nodes will slowly. Then we modified we preserve muscles of the chest. And now majority of us will do breast conservation surgery. What is breast conservation surgery? If you see last two pictures, you will not able to identify the scar and where you have done surgery. But what is breast conservation surgery? You have to just remove tumor with 1 centimeter margin and and if the margins are negative, we don't need to do any but patient needs advanced radiation. Now, after breast conservation surgery, it is more minimally invasive. What is it? Is a sentinel lymph node. What is sentinel lymph node? The word sentinel itself means as a foot guard. The first node in the training pathway of the tumor is a sentinel, and if that node is negative, we don't need to do complete accurate lymph node. You can see in the first picture there is a pectoral presentation. Now the second picture, first green, second eye, third is blue. The second last picture is methylene blue injected. First is indocyanine blue injected and the removed. If you send this lymph node to pathology and if pathology is safe improperly with this node is negative, you don't need to do the lymph. So breast cancer surgery has become now as a daycare. In this picture you can see the lump has been removed and it has small incision that we can remove the lymph node and patient comes in the morning and they go home by the evening. So this is organ preservation or conservative surgery in oncology. Sometimes we do get patients with advanced disease or someone has operated see the scar, we do reconstructive surgery. Now reconstructive surgery or oncoplastic surgery are two parts. One is done by oncosurgeons themselves, but in some cases, plastic surgery is needed to do this surgery. These are the pedicle flaps which oncosurgeons do get to. If you see the scar below the breast, now first principle is oncological clearance. We have to take at least 1 centimeter margin. And if that defect is big, we have to reconstruct that. And in this lady, the defect has been reconstructed by ELT flap. That is muscle flaps where we take skin pedal and we reconstruct the same picture, what has been removed, how the defect has been reconstructed. So these are all advances in conservative surgeries as well as reconstructive surgery, which give us a better result. So as well as in prevention, in treatment, and if we detect cancer at an early stage, probably more and more conservative surgery will be able to do their sentinel lymph node biopsies can be done and patient can go early as well as their psychological status is also maintained. Now regarding gynecological diagnosis, cervix is the most common diagnosis, and my sincere request to all of you, no more silence about gynecological symptoms. That should be message which should be given to the society. What happens in day-to-day life? All the people they are busy working, they neglect their symptoms. Even my intermenstrual bleed, postpartum bleed, as a physician or treating practicing doctor, we should make people aware that these are not the normal symptoms. And in the routine history training, if we ask some questions about menstruation, if we ask some questions whether they have lump in the breast or any other lump, we may make them to speak out. And in that case, we can take that opportunity to screen them or detect cancer at an early stage. Now, the most unfortunate thing about cervical cancer, 90% of cervical cancer are due to HPV. HPV is 16 and 18 is the most common viral strain. And the time gap between viral infection to development of cancer, it is more than 10 to 12 years. So we have such a big time span where we can detect this virus, we can eliminate this virus, and more important than that, we can do vaccine to the young girls. If you see in primary prevention, we can vaccinate girls between 9 to 26 years, but before sexual activity starts. If you vaccinate with cervical vaccines, almost 95 to 99%, we can protect all of our young generation from developing cervical cancer. In India, now maximum cancer-related deaths in female are due to cervical cancer. It's a really serious issue where vaccine can prevent it. Patients are dying because of that. So, second most nowadays, in US there is a vaccine which is available above age of 45. Up to age of 45. It is not in India, but soon we will see that if even during sexual activity we can vaccinate females and prevent this cervical cancer. Because the duration between infection to development of cancer, we have good long period where we can prevent this cancer. Now, the same principle applies. Now, if you see the guideline, perhaps we don't have to do pap smear every year. It is every 3 years ago. Or HPV DNA plus pap, which we call co-testing. Co-testing, you have to do once in 5 years. And WHO recommends only one pap or one pap plus HPV DNA testing once in a woman's life. At least that much we can do. And if one pap smear is negative or one HPV DNA plus pap is negative, that's sufficient. And if there is any abnormality in that pap smear or HPV DNA is detected, we should vigilantly monitor this. So this is such a beautiful test available, easily, costly, and anyone can do running open basis. We can take pap smears with breast cycle. So these are the advances in cancer prevention, and we should take care of this. Now, what are the warning signs? We know abnormal bleeding between the periods, bleeding postpartum, and bleeding during menstruation. If you see the cervical cancer staging images, if the disease is limited to the cervix, then only we can do surgery. Otherwise, we have to go with more advanced. So laparoscopic radical surgery, my previous speaker has already mentioned, we can do that. Next is ovarian cancer. Unfortunately, we don't have any test, but knowing common symptoms, if we learn about early satiety, protein, urgency, urinary symptoms, we should be very patient. And it is really difficult to diagnose ovarian cancer, but any symptoms which are lasting more than a month in an elderly female, we should evaluate for. So, complete cytoreduction is the most important thing in ovarian cancer. You can see the specimen, remove peritoneum, remove omentum, all the uterus, everything we have to remove. Means entire abdomen we have to clear. And now, what is advances is I'll take just 2 minutes and hypertonic intraperitoneal chemotherapy is the standard of care. It is a recurrent boil chemotherapeutic agent to 40 degrees Celsius and keep that fluid roaming within the tummy for 90 minutes. It has shown to prevent majority of the recurrent ovarian cancer. Rather than putting patients on only chemotherapeutic agents and more immunotherapeutic agents, to a best good quality surgery with hybrid that improves quality of life as well as prolonged. Colorectal cancer, I already told you, fecal occult blood testing has been shown to reduce mortality. All the colorectal surgeries we do in the laparoscopic and it is the standard of care now. If you see, there are some patients here we don't have it, some patients we can do from the same incision and take out the specimen from the same. So, laparoscopic colorectal surgery is the standard of care, and fecal occult blood testing is the most important test to prevent colorectal cancer. Oral cancer, last and not least, if you see persistent patches in the oral cavity, any abscess in the mouth, and we need to. You can see this female. What is the goal of what I said, now it is not only cure, it is also patient's own body self-image. Social patient should not be specific this female. I have myself welcome and she is depressed and looking. So what has come conservative surgery? That we can just, if bone is not involved, just to get margin, we can do marginal mandibular and we can do more advances are in oncoplastic surgery where we can reconstruct mandibular arch with bone like arc palate. We can reconstruct with. So there are advances in cancer surgery along with reconstructive surgery, and we can do very good. In nutshell, take home message: prevention, breast self-examination, mammogram, cervix vaccination, HPV plus DNA testing, colorectal fecal ocular blood test, and colonoscopy. Treatment: cancer surgery is nowadays not a mutilating surgery. We can cure patients with good treatment and cosmetic. Minimally invasive surgery and organ functions preservation surgery.
Thank you, Dr. Sumit, for excellent presentation. Few questions from the audience will be entertained.
Very nice presentation, Sumit.
Thank you very much.
I request President Dr. Peanut Deshpande to felicitate Dr. Sumit Shah. Chairpersons also to join for felicitation.
इकडे समोर. Thank you.
I request Meenakshi Madam to felicitate chairpersons as well. Marathi sir, please join for felicitation.
इकडे समोर. Thank you.
We declare this session as over. We come back at 3 p.m. for cultural program. Madam has a few announcements to make.
Anybody wanting an extra lunch coupons is available at Ms. Neha, or anybody wanting an extra banquet coupon. So please have yourself. Program from 3 to 7 p.m. is totally free for all the guests. So you need not worry about when to come and when to go. If anybody wants extra banquet coupons, they are available. And tomorrow we will start sharp at 8 o'clock in the morning again with breakfast with experts. I will send the required slides again on our registered delegates group. So you will know what we are having for a feast of tomorrow's feast. You will come to know today evening. We meet again at 3 o'clock sharp.
आम्ही दीपक सरांची थांब एक मिनिट. सर बंद करू का कॅमेरा? बंद केला का? ब्लॅक केलेले बंद करू का? वेलकम टू
हाँ रिकॉर्डिंग अभी